Museum for Wales, absolutely beautiful environment. I'd like to give a particularly warm welcome today to Councillor Rodri Evans, who the Minister has recently appointed as our new independent member of the board, representing local authorities. We're very grateful for his experience and his knowledge, and I know his commitment to anything bringing to the board, so do well. We're going to start today with two videos. Today is Carers' Rights Day. And the first is really outlining generally carers' experience. In the last census in 2011, there were 47,000 carers in Howard, and we expect there will be even more than that when we get the 2021 census. The second video is showing, is basically highlighting the Larry score. It shows the support that we're providing to unpaid carers when the person that they care for is leaving hospital. I'd also like to add to that I'm really pleased that in the health board we do have a carers policy and a carers passport, which can be used by employees and line managers, and we also support our staff through a peer support group. And at the moment, on this Carers' Rights Day, there are stalls throughout the whole of Howard Bar with Admiral nurses, with Macmillan nurses, with people from HR, reaching out to our employees and reaching out to unpaid carers to give them advice and help to support them. We're going to play the two videos now from there.
Hyggingen.
She looks after mine. She looks after my nan. I do feel good about looking after my mum. She's confident, flexible.
She's lively, she's interested in people.
Vibrant, maybe. Drained. Sometimes I feel drained. It's that balance of the whole work, life, family, and it's very difficult. I probably dropped all of my work a few times to be able to look after my mum. The juggle work and I juggle with my parents. Start work at 7:30, but before heading out to work, checking in on mum to see if she's okay, and then go to work. It was just, like I said, the relentlessness. That was so blooming hard to manage, rushing around, keeping all those balls in the air, and exhausting.
Members of the public, I don't actually think they could see the video, but they could hear it. So what we'll do is we'll make sure to be able to the board papers by that particular item. So I do apologise for that.
Oh, my careful, I'm mobile.
And we're very good friends with his mum.
I love dancing.
She's fun.
I think I'm kind. She's confident, funny, kind.
If I'm honest,
One word.
Joyous.
and I ended up in hospital. I felt awful.
Heavy.
Really just supposed to be talking over each other.
The doctor said, "Yeah, you have the capacity to make your own decisions." So an assessment was made. Mum wanted to come home, but I soon realised I wasn't going to be able to cope without some help. The ward sister was so kind and gave me the carer's information pack and a leaflet about the carer's discharge support service, and she recognised that I needed support too. This was an eye-opener, as I didn't see myself as mum's carer. I just saw myself as a son doing what was best for them. I called the carer's officer. That's when I met Sam. I needed to attend a discharge meeting. I was finding it very confusing. There were several different people there who were looking after Mum. I was really grateful that Sam was there to support me and made sure that the team listened to my views and concerns. Sam said there were other agencies that could help me and Mum, and she got home. Sam asked questions that helped me understand what was most important for me. I don't know what I would have done without Sam's input. I think I would still have been so confused as I didn't know who to ask for help. Sam also helped me and Mum understand what financial support was available, such as the carer's allowance. With the increase in the cost of living, money is a big worry. Sam gave me the confidence to speak to the people involved with Mum's care when they were planning to discharge her. I also now understand who would be involved in her care when she comes home. I really benefited from the carer's discharge support service, as Sam had the time to talk to me about my needs as an unpaid carer, whilst other professionals would focus on Mum's needs. I'm so grateful to the ward staff for handing me that club.
Having carers officers who can visit our wards is a huge asset. They have time to talk to unpaid carers about their own needs and share information about carer support services. They also play a key role helping to involve family members in the discharge plans and enable patients to regain independence at home.
The Carers Discharge Support Service is a project funded by the West Wales Care Partnership through the Welsh Government Regional Innovation Fund to provide direct support for unpaid carers. To find out more, email carersteam.htd@wales.nhs.uk.
Thank you, and my apologies again for technical problems. As the board secretary said, both videos will be available on our website. So I now go straight into the agenda. We have, as usual, a very, very full agenda. I'll ask people to accept that everyone has read the papers and just confine themselves to any additional information or specific issues. So we go straight into apologies.
Sorry, yes, Chair, we've got apologies from Dr. Mohammed and also from Kate Bwrdd.
Thank you. Any declarations of interest?
Yes, Chair, there's two declarations of interest. I'm going to participate in the item of industrial action as a member of the RBC and the trade union representative on the board. And Manfred has also declared an interest in the same item. However, with a special accountability performance, the race director will be able to participate in that item, Chair.
Many thanks. We then go on to the minutes of the public meeting held on the 29th of September. Is everybody happy with the board minutes? Happy to approve? Many thanks. We go to the matters arising and the table of actions. Are there any issues on the table of actions?
Yes, if I could just add some detail to PM 22157, please, Chair, because I did say in that I was saying about direct payments and the short-term opportunity that existed through COVID to allow families who were able to do so with some payment to take people home. But then also clarified that direct payments is a mechanism that's considered every time that somebody is going through discharge and is considered in terms of the appropriateness for the individual and family and the opportunity that gives. And the numbers I presented there for Ceredigion and Carmarthen, I was going to update for Pembrokeshire, so I've now got the Pembrokeshire numbers, and there are 435 individuals currently receiving direct payments in Pembrokeshire, with another 66 pending the arrangements being made with a personal assistant. It does seem that the challenge of actually recruiting personal assistants is something of a bit of a barrier, really, in terms of helping more people to access that in a more timely way. And you could see from the figures that I did put in the table, we similarly had about 70 individuals waiting for the recruitment of a personal assistant in Ceredigion as well.
Thank you, Jill. I think, as you know, Paul raised this issue a number of times, particularly because one of the, in England, that there was an expedited way in which to access direct payments to enable discharge quicker. One of the greatest challenges that people face is being laid in hospitals and not being able to access the care that they need at that time. And I think currently we have 305 people in our hospital beds who don't need to be there. We're doing lots of things, including the alternative care unit that Mandy's leading, where people can get care for a better environment, where that meets their needs more than the hospital. We know all what happens with people in hospital, how they can deteriorate, etc. There are lots of things that are happening, and it straddles health and social care. So I'd be really grateful if we could have details of that coming to the board, so the board can consider the effectiveness of it. So even in that, we've got the numbers, but we don't know how long they waited, how many people have applied, or how many people are waiting for a social care assessment in order to apply. So we need that detail, because there's so much we're doing at the front door that we need assurance at the back door, that with our social care partners, we're unlocking the system for the benefit of those we collectively serve.
I think that's a really important request, actually, Chair, so that we show that whole system. And we're having very, very close conversations through our integrated executive group now, almost in the format that we previously had around the health and social care tactical group on this whole issue of patient flow and discharge. So I think, I know Andrew and myself would want to present a report at a future meeting to demonstrate some of the evidence that's available.
Thank you. Thank you. And it also fits in what the Minister said to the Chief Executive's Minister of Health and Social Care yesterday. We can't keep on doing the same thing. We have to really, really think radically. Mandy, did you want to come in?
It's actually on a separate item.
Okay, thank you.
Yeah, it's PM 22-118. I think it's just a typo, just for people to be clear. It's actually April 2023, not 2022.
What did you want to come in?
So it's PM 154, and we might have met yet to talk about this. So I think we can make the case so that we've got 2,500 people being waiting list. When the internal audit report came from our, there was a lot of information in there about how we were not necessarily applying the systems correctly, therefore people on the waiting list. We shouldn't be there because I think it's so I'm just concerned to see that we're removing 2,500 people that was no way to get my question. Or how do we do the lessons? How do we apply the lessons which we learn from the internal audit report?
Thanks, Paul. I think in terms of actually validation will be an ongoing issue and part of both parts of managing our waiting lists across the health board. We've appointed Jim Plunkett as head of our validation team to make sure that we've got a real tight grip and rolling process to make sure that we're always on top of that. So my hope would be that, as I say, it will always be an ongoing part of waiting list management, the validation process. It needs to be to make sure that we keep this as clean as possible. By having that individual in post on the work we've done so far, and ourselves internally, and the work that we're Welsh Government commissions, which we're using in a complementary way to support the work we've already done, I think we'll be able to maintain our list in a much cleaner place than they've historically been, rather than getting into this sort of peaks and troughs scenario whereby we address it, we don't have an issue, and then we address it, and then we have another issue. I think we'll have a more consistent approach, but I would anticipate there will always be removals through validation.
As you said, I think one of the keys, if we should have removed the avoid, is this sort of exercise where we have to go up and engage consultants, and I think considerable expense to do an exercise which, as you say, should effectively be managing ourselves.
That's certainly what we're going to be trying to do.
Is this the need for the meeting that hasn't taken place yet? Go into more detail.
We could possibly engage it, so making it do that, acting on that rather than
We'll not have to compute then. Thank you. Any other issues on action on? No? Okay, thank you. If we go then on to the minutes of corporate trustee meeting held on the 29th of September, the trustees happy to accept the minutes. Thank you very much. Then we go on to my report. I'll take it as read, it's quite a lengthy report, and I'll just draw your attention to two things in the report really. I'd like to, on behalf of the Health Board, express our sincere condolences on the passing of Dr. Matthew Sargent, And as you know, Dr. Sargent joined the NHS in 1997 and he was a highly respected and looked after colleague who always focused on his patients. And you can see the report, there's so much detail about the incredible awards that our staff have won right the way across the piece, including the NHS Wales Awards, where we won 4, including the Special Outstanding Contribution Award for the Carmarthenshire County Council and the Health Board project for intermediate care. And similarly in the West Wales Health and Care Awards, and they're all in there, but I think it's particularly inspiring that our staff are winning national and local and regional awards at a time of unprecedented challenge in the NHS. I'd like to commend them. So I'm open to questions on my reports. Yeah.
So not so much a question, just wanted to say something very quickly about Matthew Sargent. It's really sad to notice passing, but impressive array of awards in the paper. Actually, he himself won the Outstanding Achievement Award for clinical teaching. He was a phenomenal intellect and a great support to me and many colleagues. I know across the health board and outside the health board, but his real passion was teaching, and he consistently, for many years, had the best rating for students. So that's why he won the award.
Thank you for sharing that. Are there any further comments or questions on the board? Yes, thank you. Everyone happy to accept recommendations in my report as well. Now we get on to the report of Chief Executive.
Thank you, Chair. I'll be similarly brief. First, I'll just say it's lovely to be here. Lovely to be here in person with most of the board. It was great to do this. But just to pay attention to the corporate team who pulls all this together, because it wasn't an easy task to do. So thank you for that. I'm happy to say my report as well. I just wanted to particularly highlight the arrangements we've now put in place following the change in our escalation status to target implementation, finance and planning, and enhanced monitoring on performance issues. You'll see in the paper I've included the terms of reference for the establishment of a steering group internally that I chair, and our chair is in attendance at, and the 2 working groups working respectively on TI and enhanced monitoring issues. Work started already. We've had a number of meetings on a weekly basis of all those groups to build the momentum. The first product of which was the submission of the performance plan on the 11th of November, which we know the executive officer included in his report as an appendix. To reassure the board, as we are producing documents and evidence, that will go through the full public board or through development committees for scrutiny, and it's going to be largely around putting together all the work that's currently going on. So I'm happy to take any questions on the figures and those.
Any questions? Judith?
Yeah, thank you. Thanks, Steve, for the report and papers. I guess my question is one of seeking assurance that status is not putting undue extra pressure on the executive team and those who work for them. And that's in the context of everything else that we're seeing on this agenda that is still progressing. And it's not so much, I'm not asking that from the point of view of questioning that Welsh Government decision. I do have some questions, but just it feels incredibly bureaucratic, all of the requirements that have to be established. And so I'm seeking assurance in terms of the additional pressures, but also that it's not distracting from all the other work that you were all as a team carrying on. We were all seeing frequently reported at the board. So just with some assurance on those 2 points.
Thank you. Yeah, I think it is worthy of reflection, because clearly this is particularly in the inception stage. There's quite a lot of work to pull together. You've got something like 68 actions on the action plan. I think to take a positive, two positive points out of it, one is this is a much more structured process than previously. So I think in getting through the initial sort of inception stage of this, I think we will then be in a process which will be easier to manage potentially than previous escalation arrangements, simply because we know what it is that we're needing to do, which wasn't always clear previously. I think the second thing to say is what's very reassuring about the requests from Welsh Government is what they're asking for things that are already largely in train. So I think there is a degree of corralling a lot of what we're doing to go on pace in the 11th of November. So I hope it helps the board as well. So not wasted energy from that point of view. But it isn't having a huge amount of additional work just because reassuringly and perhaps unsurprisingly the issues which we've been escalating are the issues which we were working on anyway. So I hope it does give some reassurance. It has certainly been a lot of additional effort in these sections.
Thanks, Chair. Steve, a couple of questions. The Swansea Bay City deal, what are the benefits going forward? We actually 50,000 times. What are the benefits to have going into that deal?
Yeah, I think that the key product for us at the moment, which is becoming more and more tangible, is the control development financially. A long time in play, we've had a key input into that, and part of this money is supporting the programme manager that's pulling that as well. So I think that will be really important for the next year. I think more generally, it keeps us at the table in discussions around what is a significant amount of money coming in from the UK ultimately. And we need to ensure that we're around that table and pass that with our large benefits. We've got that very practical product coming in.
Okay. Another area, the industrial action which we report, also we differences in industrial action. So we have any clarification from the RCN about which services will be protected as part of the emergency care.
I think that discussion is ongoing both nationally and locally. I don't remind you if there's anything or Ali would look at.
Yeah, so we've established the industrial action planning group which I'm chairing. We're meeting twice a week at the moment, and we're going through all of the detail to assess what the impact might be from the staffing perspective, and obviously then the impact on service delivery. We are also actually putting together a list of the service areas that we feel are critical that need to be maintained, that we will then obviously discuss with the trade unions. And when a steer comes from national, as a national group as well, we will overlay that, but we felt that we needed to get on with the planning because effectively it could be 14 days notice, so we didn't want to wait. So there's a lot of planning going on. I'm feeling comfortable that we will have a detailed plan, and conversations have already started with the trade unions.
This is just worth adding to that, but a lot of concerns I know we will have in the event that there are this strike action that will have an impact, particularly on our current care delivery forecast.
Could I just add as well that we're also waiting for all the ballots to close between tomorrow and the end of December, so this actually could be much bigger than just the RCN. So we're planning for the entire workforce.
Where will that be? When will the board be updated as and when it unfolds?
Well, we can certainly update electronically in between, because we may well find ourselves in that position before the next public board meeting. We'll certainly circulate it and keep members up to date.
Thank you. Chantal and then
Yes, I think it's just an additional question on the industrial action is whether at the stage we know the percentage of staff action will go on strike, and how we are managing the work that we've already agreed that we were going to do, and what impact that will have in the future.
We currently don't know the numbers, but we are gathering that information as we speak. So it's very quick moving piece of work, so we should have that information fairly shortly. But obviously, depending on the balance of the other trade unions, we may, this is going to be a piece of work that's in the trade for quite a few weeks, I think.
and whether it will impact on, you know, all of the work that we're doing in relation to the targeted interventions, etc. So just for us to have an idea as to where it all fits in.
I mean, it's difficult to know until we know some of the details, but I guess generally the perceptions will be we have to run on days of strikes, we have to run sort of Christmas Day or what the bank holiday type service. And we know that in relation to that particular passing of the Queen recently, that was about 800 applications, for example, that has to be within country in the range. So it could be about impact, but it will really depend on exactly who and where, and we don't have that detail.
Do you want to come on the same issue?
Yes, just on that issue, and I think it's going to be a really important part of the working group, and thinking about the impact on the past systems. So when we do have reduced services in our acute system, there may be, well, added impact on primary care services, which are already stretched because of individuals who are waiting or requiring more support. So I know that they'll be looking at that whole system.
And we do have primary care on the table about doing this stuff.
I think the crucial part here is communicating with our public. And I'm just wondering how our communication strategy is developing and how we are kind of preempting some of the issues for our public, because they're already concerned. People have been waiting significantly, and this is only going to cause further anxiety. So I'd like to make it clear really about communication with our public in advance, if possible.
Yeah, and just to assure you, Paula is part of the group, and we are considering both communications to the public, but also to the staff. So we are trying to preempt, but obviously we won't be in a position to communicate anything until we have some of the detail.
Shall I just reassure that some of the lessons that we learned through the process of communicating with both our patients and our colleagues through the Queen's death and the funeral, will definitely replicate what we did there to ensure that we have individuals aware of what's available and what isn't.
Are there any other questions?
Yeah, more than observation really, and so thank you for the report and the benefits in relation to tax intervention. When you look at the action plans, it looks like all those are outstanding, but actually there's quite a lot, you know, that will already done. So I think it's worth for just noting that, so for example, there are things like quality SRO or tax intervention and around stuff, we've done that already. I was just thinking that as from the public point of view, it's like these are things that will get to be done, but actually we're already doing it as part of our business as usual.
I agree with you. Actually, a lot of the actions were addressed with the 11th of November submission as well. So we've got a project manager now alongside us who's going to try and keep a track on all of this because it's quite complex tracking being done. I'm hoping once we start to clear the decks with the early actions, we can focus on the review and that will be part of our discussion in December.
Thank you. I remember the independent members this week. I think the consensus opinion is that we would expect that the targeted intervention is to support the executive and the liaison management being done, and not be overly bureaucratic, and not distract from the delivery of the services and the delivery of our own strategy and moving along with our strategy. It mustn't be a diversion and a tick box exercise. And as you said, Steve, in your opinion, a lot of the actions in this we were already doing. It's just bringing them together and evidencing. So I think it's a message that the independent wants to share with the executive. So is everybody happy to accept the recommendation of the executive report? Many thanks. The next item on the agenda is the report of the audit and risk assurance committee. Paul.
At the end, there are sections of the which point to the attention of the board. First one is specifically recommendations to the changes to the scheme delegation, which also provide finance support. The second one from there is a sort of standing effort that I think our report now and discussions we have the questions for us raised when we get to the finance support in relation to that. So now that is your report will be
Thanks very much.
Yeah.
I think I've just been asked by the board secretary if you all speak up because all of us, including myself, it's very difficult for the public to hear. Are there any questions in relation to the ARAC report? Could I make one observation, if I may, and it's in relation to the Welsh Community Care Information System, and based on the audit report and based on the experience of the users of district nurses, etc., that the decision has been made not to roll it out to the other two local authorities. And I just wondered if you want to come in and explain a little bit about that, because nationally there's a drive for us to adopt it, but our frontline staff do not find it useful.
Could I just have context for that as well as it was but I think this is a follow-up report which audit really kind of talks to the case and the deficiencies in the system and the way in which it has not been applied in the commission of the scheme that it first commenced. It's way behind target, it's way over budget, and it's not delivering the services and the benefits which people are anticipating. So something that will watershed to them going forward. There are some organisations who are currently using it, who are thinking about not using it, from the current contracts currently. So it's by no means something to go in a positive direction. And the format and all the way support is one of the number of the scheme which are not, positive to the way through.
Thank you, Paul. I think you need to share that with the Minister for Health. Hugh?
Yeah, I think there are a number of observations to reflect on with this and some lessons to be learned nationally. And firstly, to say it's from a policy perspective, I think it's a very noble ambition to have a common system between health and care, and something that we do desperately need. Largely, this has fallen down in the implementation stage. And a number of reasons for that. Firstly, the system has been co-developed with us and wasn't a system that was operational and robust anywhere else that we were lifting and bringing in. And there's always a degree to which systems get developed and updated in local implementation, but this was much greater than that. And I think as a result of that, there have been challenges in terms of how usable and robust the system is in terms of its reliability, which has been challenging. And second, the major issue then is how mobile that system is. So there is an intent for 4 years now to have a mobile app coming out from the systems. They're not in place. And that means that many of our community staff have to double document, once on site for patients and once then back into the system when they get back to base. So it's an inefficient way of deploying our community staff, and it's an issue I would imagine across social care as well as health in Ceredigion. We have deployed it in other areas other than Ceredigion, notably early start and the school nursing team. The issues are very consistent. I don't propose that we roll the system out any further, and we need to certainly think of what our plan B would be for adequate use of that system and the potential replacement to that system when the contract allows.
I think it's important I raise that with the Minister, so that she can hear directly from the front line. I've asked to meet some frontline staff to hear their experiences directly, and I will invite her to join me.
As you put it up as a sort of audit way to report it, this will not out our specific report.
Thank you, Paul. Any other questions on the report from ARAC? Thank you. We now go on to the Quality, Safety and Experience Committee.
Thank you, Chairman. My report stands, but I would like to take this opportunity to underline the committee's engagement in work relating to enhanced monitoring, which is the theme of the agenda. So I would like to start by reassuring the board that each of the issues raised specifically by Welsh Government in relation to enhanced monitoring around the quality of our services, which include urgent emergency care, some patient experience issues in maternity, our counselling and rates, have all been switching on us through our committee over recent months. And we always welcome our HRW colleagues to those meetings and attend on a regular basis to observe the discussions that we have in the committee. However, I think Mandy and I speak as one in agreeing there was no room for complacency on any of these issues, and therefore we have agreed that the December meeting of the committee will be extended, and we will cover each one of those items, go back to it, to look at progress, to see where we're at, to spot any gaps that we may have in our assurance or our work that we are doing, and we've extended that meeting to allow ample time for that to happen. Much of the time, I'm sure that all members of the committee, Mandy and myself, most joyous about that. However, we do want to make sure we have meaningful discussions. So each of those issues, if they weren't already included on the agenda, and we've added as new items, standalone items ought to be incorporated within existing items. And so I would suggest that at the January board meeting, we perhaps provide a slightly fuller report to the committee for the board's Cyhoeddus and assurance on those specific issues that we're raised through enhanced monitoring. Mandy and I have also agreed that we will stand up our touchpoint meetings that we instigated through the worst of the pandemic to ensure that we have a regular communication between bi-monthly committee meetings, and the first one of those has happened. And as the chair of the committee, I also have an open invitation to observe the enhanced monitoring working group, and I will indeed try to do that on a regular basis. The only other thing that I might say at this point, I think, is given that quality and money are really two sides of the same coin, I wonder if there is perhaps a conversation worth having with my committee chairs across SLC and ESCO, just to see if we are missing anything in terms of connecting ourselves with executive leads for those respective committees as well. And I'd be happy to take that as an action to convene that discussion if that is something that those would be interested to do. So I think just by way of pulling that together, I think while we can and we do subject these matters to really close scrutiny, they have been on our radar for some time, will continue to be, along with a wealth of other issues that we cover in our committee business. The risks remain very high, and I do not want any member of our board or indeed public observing today's conversations to be under any illusion that the risks of our services are substantial, that that has an impact for our communities, patients, families, and of course for our staff. And we are cognizant of that in the way that we conduct our business, and then we're uniquely centred on those risks that remain, and we're also absolutely.
Many thanks, and I can see so many nodding heads of members around, including the chairs of SRC and SDOC, to go forward that way. But it's really reassuring to hear what assurance here. And I think it also goes to another some perception that we as a board may not be cited, and it gives evidence that we are cited and will continue to be, and enhance our scrutiny indeed. Mandy.
If I may just come in, the board secretary and I are actually meeting with Jill from the chair later on this afternoon, so that we can make sure that we understand if there are any concerns about lack of assurance. What is it that's more required for them to gain that insight or level of detail? So that conversation will happen this afternoon.
So look forward to hearing the output.
Just like that, you're right, meeting based on the
Any other questions or comments? Many thanks and very well. Thank you. So the next item on the agenda is the board assurance agreement.
Chair, so since the previous board meeting went back to July, the board meeting with development committee, so you've been able to see through the update reports. We've also reviewed the outcome measures on the exec team in their detail in the paper, and the principal risks have also been reviewed by the exec team, and they've all been updated in section 1, which will be updated in the next couple of weeks. So in summary, and rather than go through the detail, because the detail of each executive lead is just to flag that there's currently 7 common objectives that we have, and I'm aware from the paper that we do need to carry the bacteria because we're not aligning to TSR, so I apologise for that. There are 7 behind, which is a deterioration of 3 of the last 4, and 2 are closed as well.
Many thanks, Joe. Any questions? No.
Thanks, Chair. Just spoke about the mentioned the funds to be fund. And I was just wondering, are there any of the plans that was in particular concern around the executive?
We obviously want to get on track with all of them. The ones that are behind this probably is some conduct issues behind it. So I think like on by strategy, we will be talking about we'll start to make some progress in coming out what we've been through over the last 12 months, and just some of them taking it into action. Any that aren't completed by time schedules will move into future year and have a discussion again about the whole relevant and objectives that we're doing on the next year. To ensure that we are balancing the ambitions of being realistic about what we can do.
That's due to our issues recruiting to regional lead. I'm really pleased to say that actually we'll be able to report we're not aligned because we've just managed to get some views from the position there and then be able to start building a team. And thankfully we actually work around the obesity pathways that sits alongside that objective. It is all on track. So I think there's a couple of reasons for that. I hope certainly public health ones I don't have concerns that there's one on track for the next meeting.
Thank you.
Yeah, just a query in relation to 5K, because it's determined and just in the year, 7, 20 year, what position is in relation to that, we did what we did to.
Oh, yeah. So yeah, in terms of 5K, we did have a bit of a gap in personnel, so there was an issue with capacity, which did put us back, I think probably about 6 months in our plans, but they're advancing quite well now, sort of developing that strategy. So and that's reported through quality safety experience committee. So I think I don't have any sort of future concerns around the progression of it. There was that sort of delay for 6 months.
Could we include that possible in the future update?
Sure.
So be clear about what's happening.
Yeah, thank you.
Yeah, just a quick query about 3G and research and innovation. I think it's indicates on tonight, but my perception is the board having to try to in your business plan and the goals going forward. But it's not actually like we're doing quite well with that particular item. So.
Yeah, there was a moment in time where there was a couple of things where we were quite self-critical about our progress. And I think now we've caught up and we feel we're up to date with all the actions. In fact, it made the time because we recently had our research innovation subcommittee where we reviewed the progress and actually the committee is assured that we are now up to date with all the actions.
So that can be amended next time. Thank you. Chantal? Yes, it's just in relation to one theme, in relation to the waiting list initiative, because given that there's a potential strike on the horizon, and Deliath mentioned earlier around having a communication strategy to move towards patients. And I did note that as part and parcel of that, that we were going to be using a systematic approach to measuring harm, because obviously the waiting list still, these individuals will continue to be on the waiting list, and whether we've already designed that system in order for us to be able to ensure that the one that needs the interventions is being dealt with, given the challenges that we're going to be facing.
If I can come back on that. In terms of the waiting list support initiative, within this month's board report around patient experience, there's quite a lot of detail there around the impact that the initiative is already having. And in particular, there's actually a patient story that highlights that where the contact is named and the need has, somebody's need has changed, but the action is individual. So I'm fairly confident that the way in which the system is now working does help us capture on the individual basis the specific needs and harms that are being experienced by individuals, so we can counteract that. We've got the harms dashboard that has been developed as well, which is something that we're going to be taking back through our formal executive team meetings, so that we can keep track of where we are around various harms. But we are seeing across the system, there's still a bit more work to be done on that, there always will be. But the other thing that I was going to say about waiting list support and the command centre, we're increasingly merging those two activities. So where we need to set up a cell to be able to support communication out to our public, we also have the capacity and ability to do that as well. So whether it's industrial action, whether it's fuel issues, whatever it may be, we have the capacity to be able to set that set up for our population, for residents and our staff as well.
If I could just raise a question on the increasing community capacity. We say in that our initial aspiration was to increase capacity by 140 additional bed equivalents, and yet elsewhere we say it's 117. And I know the national report picked up a figure. I just wondered what our initial aspiration was.
I could probably answer that because there are a number of numbers.
Yes, that's,
so our original fair share of the 1,000 ambition for was very much action after the year of summer, and was 140. Our plans initially, as a health board, we looked at how we might address that through additional capacity. Did come to something like 117, and that ended up reduced to 84 from the specifics of recruitment between Pembrokeshire and Carmarthenshire. Welsh Government are reporting back on a figure of 220, which does then lead to also quite a low performance for us against our plan. But as I understand, that number includes other figures, such as our less debt work, our front of house work, which was never supposed to be included. So we have the denominator nationally is overstated. So really our denominator should be 140, that was our fair share. We're aiming for 80, and we had some more challenges of recruitment, so but no reflection on the amount of effort that's going on to try and get that.
I think the most important issue here is that, particularly for the public and also for our new member, is that the health boards across Wales knew that coming to the winter there wasn't the social care capacity to enable people to leave hospital so that you could do operations and ambulances could get out there and bring people in, people from A&E would get into beds in the way that it should happen and as quickly. So together we try to create 1,000 equivalent bed capacity, community care capacity within all our different areas across Wales. We haven't succeeded during, and one of our papers will explain why. There were a lot of challenges, difficulties to recruit, etc. I think the amount that we have increased collectively of community care capacity is the equivalent of about 400 beds, but it is totally insufficient for the challenges that we are facing. And collectively across health and social care, we need to do something really, really radical together because the health system is glued up at the moment. I think that is the overall summary really. Jill, did you want to comment?
Thank you. This is reported by the Regional Partnership Board through the IG on a weekly basis. There is data that's collected by Welsh Government and we're expected reporting to the national group. So all of the efforts that you set out there are issues we've raised. I think the challenge for us is that we've also lost beds with the closure of care homes. And I think we've seen 3 care homes, as we know, close in recent times, and that radically reduces our capacity. And we have to try to make that up. And in other ways, that's the real challenge, and it does require an absolutely concerted effort across health and social care. I'm thinking of doing, as I say, some quite radical and different things in a very creative way, and almost thinking about things that perhaps we haven't considered previously. We may have to consider with regulators and issues in terms of challenges that exist, but I know, for example, health boards are already considering becoming registered domiciliary care providers. So I've met with the regulators in terms of the opportunity of thinking about that. So, and there isn't an objection to that. Clearly, we have to go through a process. There are governance issues that we need to put in place. But I think there is that joint appreciation of the need really to do as much as we can to increase this capacity.
Thanks. Any other questions on the board assurance framework? I'd just like to say it's good to see it come live. You know, we're the first board in Wales to have adopted this incredible and detailed methodology. I remember when it was first muted and the challenge was put to you, Joe, but I think now we're actually scrutinising it and discussing it in the way we're meant to. So thank you, everybody. Next item on the agenda is the update on the annual plan 22-23, and that's Lee and Hugh.
Thank you, Chair. Yeah, so this is the first of two consecutive changes related to the annual plan, one for this year and one for next year. Members will be aware that we brought iterations of the plan to board in March and then subsequently in July. July board we did a number of measures and then brought an update to the last board in September on those measures. Since that, of course, we have now been escalated the target interventions, as already mentioned, which to some extent has superseded at least some of those measures that we agreed in July. The paper, I think, is relatively self-explanatory, but it provides an update on 5 key pieces of work presented to the September board, and namely the establishment of the alternative care unit, the transforming community care programme, the nursing workforce stabilisation plan, increasing community capacity plan that we just mentioned, and then the review of mental health and CHC packages and consumer healthcare packages. Paper also picked up what Jill just mentioned now in relation to the capacity loss that we've also experienced across some community services due to that volatility across the care market. So I wasn't going to go into any detail, Chair, to say members will read the paper, but myself and relevant execs will have to answer your questions specifically.
Thanks, Lee. Any questions?
Can I just ask on the second page of the report, it says that district Bwrdd will remove the 25% from this agency creation. Is that, do you think that is achievable?
Probably.
I answer that.
With the question that we've got, I'm just wondering if that is achievable.
So this piece of work is around recruiting to our vacancies. So it wouldn't take account necessarily of the additional capacity around winter planning. So this is around what our funded establishment is for the beds that we have available within Bwrdd, and then just going to be assessing for people around the nursing calculations. And based upon the number of nurses that we are bringing in from overseas, so we're recruiting overseas actively at the moment. We have a centralised recruitment plan called Bwrdd. We have our apprenticeship programme, our grade-round programme, and with all of that and the work that we're doing with that local nursing team, we are confident that we have a plan in place that will recruit to our vacancies. So there will still be agency utilisation, just to give reassurance that presuming we're going to not be stabilising winter pressures, because we have got agency workers covering those vacancies now.
I think just in response to that as well, there are a number of financial benefits that have been attached to this, but because of that very issue and that very challenge, I've not anticipated those benefits coming through in our projection for this year. I'm happy because if I look at the care unit and the nurse stabilisation plan, actually the risk is from a financial perspective that fill rates from agency may improve elsewhere across our sites. Now it's a good thing from a quality perspective clearly, but would counter the impact potentially from a financial perspective. And the same with the urgent emergency care work and the community capacity work. I guess the risk against that is what we're seeing with care homes and domiciliary care sectors, is losing the capacity from the community. So at this stage, they've not been included as improvement trajectories in the financial projection this year. But as we get greater assurance that we can manage those countervailing risks, I think it is something we can then bring into our planning framework, certainly going into next year.
Really just about, I just like to say that I think that the important thing as well, the reason they're not there is not as well because the actions aren't ongoing and we're not working on those things and trying to have that impact there, isn't it? When you look at the information analysis, there is an impact in the background, it's just not going through into the financial benefit that we would like to see, so that's why we'll be managing in that way. Just wanted to assure you that the work was the website level and the actions were having an impact on the system, just going through in that way.
Yeah, I just thought I'd carry what Keelan and Andrew said. We also received these items at the last meeting of this SLC committee, where we were able to look at each one in detail. We had to bring in the nursing workforce stabilisation plan, the alternative care units, to transform them into emergency care, which increases community capacity, and mental health. So what I wanted to just say is that completely concur with the views approach that whilst we're making a number of changes, we felt as a committee that we made a really good start in those areas. So we take a bit longer for actual sales, but actually cost benefits to us. I think we also recognise that we increase the demand as soon as we don't take the opportunity to build a bed out, and demand just fills that capacity. And we just felt committed that the organisation made a really good start on the strategic program of change. And we also acknowledge complexity as well. And the relationship between the hospital sector, the community, primary, and the need for that to work across together. I just want to certainly give my agreement to what Andrew said.
Thank you. So,
yeah, not to go back to the discussion we just had, go back to the support of people trying to sit and first highlights the challenges which we face in relation to joining people from hospital and effectively how we're running faster, possibly said. And in that context, I was just wondering, when you look at what's happening with my driver, what's happening in the market, what's the net position as a result of organisations handing back care packages in the market for whatever reason against the efforts which we're putting in with extra packages or extra beds and whatever it's going to be. So I think we see two things, all the efforts, and we see all the negative or some net effect. And where does that leave us in what we're talking about pressures? This leaves us in a pretty challenged position, but we just use to just get one from the other and see where we are really compared to where we started the year.
I think what's probably linked to the request the chair made earlier around what we're doing around the but it's probably a more complex picture than that, so we need to just widen the scope to look at the local counterfactuals, for example, around marketing aspects and some of the referred to. If we add all of that and see how that's impacted on the system, I think our feeling is that in the team is that we are running faster to stand still. But actually trying to put some numbers on that. It may not be easy, but I think we're trying our best in your question to try and do the whole system, because it's looking more past it.
And we could draw together the health system data and even sub data, as I know some of the frailty work is really impacted. So if we could bring that to the report, that would be really helpful.
And I guess just recognising that some of the data is not perfect, and we actually do put in requests, and these changes should be swatched up into the data, particularly around social so there's a consistent definition. But we'll use what we've got tonight and try and do some colour.
I think that will be useful for us to just understand the broad scale of the challenge and what they put on in the wider world. It's beyond that. And also it's not without it.
I think we might take one too, because I don't want to be happening. I think within that paper as well as can we bring in the projections of some of the fragility in the care home sector that may be there, and possible scenarios for the impact on us as well. That's okay. It's not us, it's citizens. Yeah.
What about not gives to the first seminar session?
Yes. Yeah.
And then we can get sent to board.
Yeah.
It's probably public details for them to do.
Yeah. I think Judith and Jill.
Yeah, it's that point actually because I was looking at the information that was just referred to. Losing 55% care issue and 88 beds. As Paul has said, they're always running to catch up. Well, not even catching up. And I know there is a sort of rag rating around fragility around care homes, which is linked to inspections, etc. But then you can also put factors totally unaware. Another factor coming in which we didn't even know about. So yeah, I think if we can do the best we can based on what we've seen not just this last year, but previously, to try and predict around the market, that would be really helpful because there has to be some realistic conversations, I think, outside of the health board with government, and certainly the regional partnership board chairs have attempted to engage in that conversation around some of the realities of the position and some solutions. But I think we need to bring it all together, so I'd still support that and everything to help with that.
Just as on the packages of care, I just want to assure board members and the public that those packages haven't been dropped. Local authorities have asked the health board to absorb them. And that's meant our reduced capacity in terms of community nursing and the sort of care at home teams that we've got to provide more care for other individuals. So I think that's a really important issue. In terms of care homes, and we have got a seminar coming up in February, so I think we can pick up those issues there. But I'd like to just pick up a side issue, if I may, which is really important in terms of care home fragility. We've been doing some work with our finance team as well to help us look at some forecasting around that. But last week was National Safeguarding Week, and I was asked to participate in a seminar, a regional seminar, and there were similar seminars across Wales, on reflections from Operation Jasmine, which we know occurred in the Iron Red area, and particularly with some care homes that resulted in significant harm to individuals and death of individuals as well. And the criminal prosecution, as you know, failed, but there was a public inquiry, and that's concluded recently. And Dr. Margaret Flynn has continued to raise the issues around accountability boards. And because it was a health and safety executive process that culminated at that point, it was actually directors of health boards that were held accountable individually rather than corporate manslaughter. So it's something that's really important. And I think, notwithstanding the care issues that occurred at that time in terms of health needs, the challenges that we've got now at the moment in terms of cost of living, fuel, workforce, etc., can easily also compromise the quality of care in our care homes. And in our board seminar, I want to provide some assurance to board members around the measures that we've got in place to continue to have that oversight, both working with our care home sector, but also providing that overall assurance in terms of the quality of care for individuals, because we will be held to account and we are accountable. And it's absolutely important that we see the new challenges that we've got can easily, as you say, cause a level of threat and potential risk to individuals in terms of the quality of their care. So it was a really important seminar last week actually to reflect again on the issues coming out of Operation Jasmine and think about the standards and measures that we've got to continue to have that level of oversight around very vulnerable individuals. I just wanted to raise that.
Phil.
Yeah, my point was that I was just reflecting on the impacts on our citizens who live in this area and our staff on your point about running to stand still, because it means that despite all the actions that we're outlining in all of the newspapers, people living in this area are getting almost the same experience, or maybe just a tiny bit better, it's incremental. So that's the result of running to stand still, and sorry to the public, but that is the experience, despite all of our work. And the other point was for our staff, that running to stand still for them means that everything they're doing in their areas means that they're still under exactly the same pressure. Through no fault of their own, so if a care home fails, or if domiciliary care or isn't able to provide, that means that all their actions on efficiency means that all they're doing is compensating for that problem. and their experience is the same. So in terms of engaging our staff in future activity around innovation, we've got to recognise that, and we've also got to recognise that our message is public, if you understand this, is that we are doing everything we do to try and improve this. Some of it is outside our controls, which is why I think Jill's point and your point about a different approach around care or supporting care homes is really needed. We really need to look at that.
I've given you the form to and then I think that's the case.
Just all the we were provided with the market
I think just directly responding to the data, and we are seeing the measure as the counterfactual, which is clearly seasonally adjusted as our expectation of activity. But we are seeing a reduction in conveyances against that counterfactual. We're seeing a reduction in additions against the counterfactual. So that will be an inevitable consequence of operational pressures, but a lot of it is down to work that is being proactively done. We're seeing an increase in the number of patients who are being turned around quickly, but then so our length of stay in a short stay cohort is doing well. But as soon as patients stay in for a long period, so the over 21-day cohort, that is increasing very significantly to offset any gain we're seeing there, and that is directly then linked to the 143 packages of care home beds that we've lost over the last 5 months. So there is a overarching story here. Perhaps what we're not doing is presenting that clearly enough at this stage. I wanted to just go back to that risk in care homes because it's a really important one, and inflation is going to have an impact. My worry is the level of indebtedness of a number of providers, which itself is going to be massively impacted now by interest rates increasing. So I think there's a very real credit risk issue into that sector generally, not singling any particular provider or our community necessarily, but it's going to be a generic issue that I think becomes a challenge for us. So there's something to keep a very close eye on in terms of that developing this.
I won't prolong the conversation, but just to go back to the operation chasing point that Jill made, is just to reassure the board and also the public that actually there's work ongoing on a national Wales basis around development of a tool that's going to help us better monitor and have early indicators around areas of concern in our care and nursing home sectors across Wales, because we, as executive directors of nursing and exec leads for safeguarding, we've recently, a few months ago, received a presentation from the 9/11 where they're learning their experiences. And we've all come back and felt that we needed greater level of scrutiny and insight into the safeguarding arrangements in our care and nursing and domiciliary facilities as well. So just to say that that work is ongoing, and as soon as it's finalised, I know that Jill and I will be working together to actually make sure it's fully implemented.
Thanks everybody. Some really, I think we're actually getting to the crux of what really matters at the moment in our system. And a massive thank you to our staff, including all the execs, who are doing everything. Is improving, really improving some parts of the system, but it just means we're standing still, as Phil said, or a little bit better because of the PAN system being broken, and we really need to get to grips to that. And apologise to the members of the public that we aren't doing as much as we wish to do because of those challenges across the whole system, and we are collectively have a duty to do something about that as soon as possible.
So it was just to say, just in terms of the action for the notes, so the board's happy we'll use the February seminar altogether a few things. One is maybe a description of the system, and that's changed the counterfactual. What we think we've done is improve the situation and whether that credit has been spent in the system. We'll do that as best we can with slightly different data, which should give us a little bit of diagnostic where things are getting better and where things are worse and what the real position looks like. We're also bringing the care and fertility discussion and the care legislation and evaluation, and then the discussion around data quality and safety committee and review that. That's months of the work that's ongoing at the moment. So we'll bring all that together and just say, we can go a bit of a deep dive as a board into all the issues, what we're doing, what's happening in the wider system. I look at it very, very important. I think at the moment, the solutions we have in place this year are the ones we're going to have to get through the winter realistically, but starting in February, thinking about what we now need to do before next winter, I think would be a good time. I should say more about none of this is a reflection on the hard work and the difficult position where we're already understanding themselves as a challenging situation.
Can we consider that for seminar, whether it would help advising the members of the IAG of our direct social services to give their insight as well? Because this is about us collectively designing different ways to improve the system. Okay, thank you. The next item on the agenda is implementing a healthy Moving West Wales strategy, and that's over to you. Excuse me. Oh, yes. Sorry, I've got it. 23-24 annual plan, over to you. Thank you.
So the plan I developed for next is basically for we will the course we're taking, of course, is very much in the context of the range aspirations that we've already talked about. So this year's plan, 22-23, was structured around our strategic objectives and plan objectives, which was potentially shorter than previous years as well. So reflecting that the feedback we had from Welsh Government. The intention for next year's plan is to build on that thought, so it'll be similar in many ways, but with more tension, probably the outputs and the Commission plans, again reflecting some of the feedback we've had from Welsh Government in the discussion at this point, and our own assessment of where our plans are relative to other health boards and where we can strengthen. We do still await the planning framework from Welsh Government as is in the paper, and that is the original priorities. But we are anticipating we have to be templates as part of the plan for this year, in a range of areas which are set up in the paper, so give you a sense of what we might look at, I guess, once we produce that document. I should say that, I guess, implicit perhaps in the title of the report and the way in which I've written it, the expectation for next year is that we will be in an annual plan position again. It's not like we would be in a position to submit a balanced IMTP, obviously that's to be worked through over the next couple of months. And then the final piece to mention is that there's work underway to how best to articulate the impact across a group of planning objectives, recognizing the number of planning objectives often complementary and they overlap in some areas. So this is working development at the moment, so just want to signal that to board at this stage. And we'll be bringing some further work on that and some detail on that to the board seminar in December for discussion before bringing more detail back to board in January.
Thank you. Any questions? Okay, thank you. Good recommendation. And then we move on to the next item on the agenda, which is the health and
So this is an update paper. We intend to get every board progress with this. The key items to note within the paper are that obviously we're progressing with the land selection consultation process. We're still aiming to get that up and running by the end of January. And then two other elements that from the Welsh Government feedback we need to progress a strategic outline case as the next stage, which we were hoping to go straight to outline business case following submission of our global business case. And the Welsh Government has asked for a strategic outline case, which is in line with the standard process across Wales. So it's not unexpected, but it is obviously a step we're hoping to avoid. That said, the significant amount of work that's already been done on the global business case means that
us in a better position than we would otherwise be for that, and actually shouldn't be too demanding for us to do that within a relatively short time period. And then the other item is the clinical strategy review, which again has now become a standard part of courses for major schemes, capital schemes across Wales. You know, other parts of Wales are going to be undertaking this same review process, and more or less the same time as ourselves, as part of their major capital plans as well. So that is a review that's going to be independently undertaken, which will be commissioned on ourselves and large government, which we're hoping will be able to undertake early next year and not impact on our timelines too much. And again, we're in a good position to respond to that, even though we're able to of course, but from the
Thank you. Any questions? No.
Just a very, very quick one. Under the next year, could start to look at that and do the overall timeline.
So we've effectively lost some time against our original timeline already, because obviously we submitted the business case in February, and we were obviously now optimistic timeline, we would have lost of that within 3 months of submission, which obviously we're not in that position. These two elements potentially do have some impact on the timeline, but what we're hoping to do is minimise that by dovetailing them with what we do with our consultation in any case. So if we can, we're hoping on discussion with Welsh Government, we believe this can be achieved, that the clinical review could be undertaken in part of next year, report in the spring, and then we could adjust the stock in light of any recommendation coming out of that, with the expectation then that we aim to keep the stock by next summer. So we're bringing the clinical review, hopefully endorsed for the business case, the stock that we then completed, and the land consultation will all come together at the same point next summer.
Any other questions?
Yeah, just regarding the land selection, has there been any kind of issues in the past and moving forward without phosphate and with the sites that you've got, have suddenly kind of put to one side, because especially phosphate is a huge issue, and I suppose by January, 96% of the county will be it will be quite an issue to have any development whatsoever. But I'm just wondering, would that be an issue with some of the sites?
Yes, so in the original long list and short list of sites that we selected, we did have some sites that were directly impacted by that. The reduced short list that we now have the 3 sites remaining, and then we have identified phosphate issues currently, that could be subject to change. So we're very much aware of it and taking attention to it. The other aspect, just think of the future of that, is the timelines that we're on should allow hopefully for some of those aspects to be resolved, because we're not be building in the next 6 to 12 months or so. So over the next few years, we would anticipate, I suppose, that the resolution to that could be achieved, but that is of course not to watch.
In relation to the clinical strategy review, just wondering if you could explain, does that include the services that we anticipate to be provided in the new hospital and the repurposed hospitals? And does it include the stepping stones on the way to that and the changes that we will be making on the way to the end, which is the end strategy?
So the first point, we've been very keen in the discussions with Welsh Government that we describe the strategy as a strategy for the way we look at healthcare, as opposed to a plan for any hospital or any other group. So we're certainly expecting the review will be looking at what we're proposing in terms of that healthcare model, as opposed to too much focus on and that includes
raise things like digital aspects and workflow aspects and so to support that. So we expect it to be in that direction. The second part of the question around the steps to getting there. Predominantly, the expectation is that we're expecting the review to answer the question: are we directionally in the right, going in the right direction? Like, how is our strategy the right direction? There will also be aspects in part of those to what progress we've made, and to what extent we've got line of sight to achieving that. But first and foremost, I think the review needs to answer the question whether we're trying to get to the right place. There will obviously be challenges along the way and bumps in the road in relation to getting there. But that will come through with the key question, I think, is whether
And the reason I got some questions, I'm wondering kind of to any of these, the fragility of services that we have, and changes we need to make in the meantime to public consultation. Could that be highlighted in this process?
There's 2 points I was going to make. One is that in part, one of the really strong drivers for us going through the transforming clinical services process back in 2018 was because of the sustainability of our services. And I'd anticipate that as part of the review, that would be considered very carefully, because the drivers have changed, and there are a whole range of drivers that are going to be really important in considering whether we should be going ahead. And we put a huge amount of thought into that in 2018 with the public and staff, and that's why we think that we've come up with the right model. And in fact, we don't have an obvious plan B in our minds. So I think the other point I was going to make is that when we went through the process of transforming clinical services, we recognise actually that this isn't people's health and well-being isn't just all about clinical care, and so also even the clinical bits of the system, it isn't all about the hospitals, and so to gain confidence on our clinical model, because we have to have the confidence of the pathways in our community and primary care, which is after all where most of our activity takes place, and the interaction with us, and of course equally our move to a more social health and well-being. So all of that will be important, I think, in giving confidence that we have the right model and giving confidence that the right hospital and the system is right.
Thank you.
Yeah, I think I'm not saying that we want the first to be doing this clinical review at this stage in the process, things come later. So just to recognise that a lot of the detail will actually come up through the OSC process and the ongoing engagement with the population, particularly around community reference sites and everything. So we've described the work as trying to get to in service terms, but leaving enough room to have that discussion about what these on different locations is going to be important. Just trying to work through that because it's quite a process.
Thank you.
Thank you, Chair. It's just an additional question about whether the review will take into consideration the collaboration across the patch in terms with other health boards as well, and how that fitting within the review, whether that is included within that.
Yeah, that's a good question. So there's reference within the draft, reference within the review that it needs to not just look at health bar services, but look at health services in the context of regional partnerships, and that would potentially be both health board, maybe health board services, but also what the relationship with authorities.
Thank you.
Yeah, 2 things. Good focus on that discussion, and again, we on board when the strategy presented at the Council Chamber in West, and that was very much clinically led, and I think we don't want to lose that.
ongoing discussion with Welsh Government on the resource requirements to support the development of the regional case. Discussions are being positive, so we're setting up what we would require for that whole process, and that would include some of the costs of our in this. So that would be part of all
I can tell from the reaction around the table that we'll totally endorse the fact that that clinical voice is remembered and carries on through this review as well. So thank you. Board's happy to accept note recommendation. So the next item on the agenda is the improving patient experience report. Mandy.
Okay, thank you very much. Really just to sort of do a bit of a recap, I won't cover every item within the report because it's quite comprehensive, but just to acknowledge that as well as concerns and complaints that we receive into the organisation, we also do actually receive a significant number of compliments and importantly, people who have experienced our services also send in big thank yous, and that's to individual staff members and teams. Because I think you can often focus on just the concerns and complaints, so it's always important to acknowledge the good work that our teams are delivering. It's also important, I think, to recognise, although it's not perfect, and I strive continually to work with our workforce to make sure that we get to 100%, but we're seeing a 93 and 92% positivity response in the feedback that we do get from individuals who take the time to offer us that feedback. So just under 12,000 pieces of feedback have been received from the various surveys that we have, and I think it's important to get that balance. We have seen an increase in the number of inquiries that have come through to our corporate team, and they are being dealt with. And likewise, we're striving to increase the number of early resolutions that are achieved. So that's responses that can be provided within 2 days of the initial contact being made, but also the number of complaints that we can close within 30 days as well. So at the moment we're at 67%, and I'm striving to get us there to over 70% consistently. Key themes continue to be very similar, unfortunately, around cancelled appointments, clinical treatment, discharge arrangements, attitude and behaviour. But I think it's important to say that we have work that we're doing around communication, because often the attitude and behaviour is often linked to poor or insufficient communication with our patients and their families. So we're continuing to undertake that work. Importantly, kindness, caring, and respect come out as key sentiments from the feedback that we receive from those individuals that provide that feedback to us. And I think that's really positive. There is, however, more work for us to do around dignity, and that is something that we have got to tackle. And again, that is often linked to attitude, behaviour and communication. So again, just to reassure everybody that there is a significant amount of work going on in that area and a variety of mechanisms for that. I'm really pleased that Mavis and Linda, those are our stories, little video clips that are included within the report, have shared their experience of awaiting the support with us. I think what I would like to call out is that the initiative has only really been up and running since January of this year, and we've already engaged with 10,800 patients directly, and that is no mean feat. And we've brought on additional services consistently as part of our plan throughout the year. And likewise, we've had 4,500 people utilise the online resources. But what I would say, and it's not surprising, you've heard me say this multiple times, using online resources is not the be-all and end-all. Not everybody can and wishes to access our resources online. The team are working really hard to make sure that paper documents, information leaflets, those are suitable for both the visually impaired, but also our online resources, for those that do wish to access them, are available audibly as well as on written text. And I think that's really important to emphasise that. I'm really pleased to see that we've seen quite an increase in our paediatric feedback this time. And again, I think that's because we've been working really hard with the paediatric services to make sure that the range of options feedback are available, not just this time in terms of reporting by age range, but also by our counties as well, so we can see any variation. So we're continuing to move forward with that piece of work. And apart from that, the only other thing I want to make reference to is the Arts in Health and First Year report. I can't believe it's been a whole year since we got up and running with our Arts in Health work. But I do think it's really important to recognise the breadth of the work that they're undertaking, both within our wider community, the inpatient areas, and also supporting staff wellbeing as well. So I want to continue with that. The reports are there, which I'm sure everybody has read, but I'm happy to take any questions.
Thank you, Mandy.
Any questions? Paul?
Could I just raise a question in relation to how we categorise these issues? Looking at page 5 of the report, we talk about the core persistence of procedural communication, and the example which we give there is partly about communication, I guess, but that's not really what's underlying that concern to express. Probably a number of treatment which is put in the sequence and that we were forward and care. So is there something that's mass related communication as opposed to care which is possible with us?
So the way in which we categorise and cut, I suppose, the different types of concerns, what you will see here is the headline. So underneath it, there'll be a number of categories. So if the complaint or concern comes in that on the surface looks as though it's about communication, when they're breaking it down, they will categorise the various sections so that they're picking up the main themes. The one thing I didn't say is that where we have got communication, for example, being an issue, and certainly in the example that's been provided here, individual feedback to individual clinicians or individual staff members where they've been directly involved in that individual's care, all the teams fed back. And we're increasingly using stories that families and individual patients have agreed for us to use. And in fact, I've got one currently in production at the moment that can be used with our junior doctors, for example. So we work very closely with the medical education team and likewise with the university as well to make sure that those experiences are shared. So it is the breadth, not just the headline as opposed to the complaint. Hopefully that answers the question.
I sort of get that, but politics concerned with the communication, and the one that's actually given as that example doesn't need it for communication, really.
I mean, we can pick it up, and I know that because we take a lot through the listening and learning, perhaps that's an area where we can do a deeper dive into communication. These that come through might be helpful, just to get assurance that we're covering all, not just the headline themes.
Yeah, we'll have that in action, that list that the Tom's complaints to listening and learning committee will keep going. Maybe not then you and then Anne.
On the funding report, you mentioned that the original group finds CSR.
Yes.
I'm just wondering how serious the cases.
So they're categorised, again, some of this is about how things are categorised. I can confirm that the one that was classified as serious has actually been downgraded to level 1, which is a much lower category following the investigation. The other complaint is currently in discussion with the family directly, so the outcome of that, it may be that they will be recategorised once the investigation has been completed. So they're categorised using the diptych system, so some of those, it's a fairly blunt instrument, and it's not until you get into the complaint or the incident or the claim or anything else that you understand the full breadth of it. And we will increase the level as well as decrease once we've investigated.
Thank you.
John, yeah, I just wanted to come back on one point, recognising the point that Mandy made around not everyone engaging digitally, and I certainly accept and understand that. As we are increasingly moving to engaging directly with patients and communities with digital responses, and the NHS app is now in development and is in beta format, with being tested by a number of people across Wales. There's an increasing challenge for us around digital inclusivity, and we are just in the process of recruiting a digital inclusiveness officer. And we will be, as the first help board in Wales actually, so that part of the, and we'll be developing between now and the end of the financial year what our strategy will be to make sure that we don't leave anyone behind. So while not everyone may wants to engage, we want to make sure we give everyone the opportunity to engage and that people aren't then left behind. And that's a really important part of the patient experience journey that we'll be working with the management on.
Thank you. That's good to hear. Anna, thank you. First to recognise the progress of arts and health. I think it's fantastic to see this. I think it reminds us that sometimes it is exactly what we need, and we need to be brave sometimes to make those decisions. It's brilliant to see that. You can time consistently out holding and understanding the risk that helps control the our own life. On another point though, I'm really struck in this report, not just this time around, but generally that when our patients get in front of a healthcare professional, on the whole, their experience is really good, to the extent that they want to tell us about good things, and that is fantastic. Where we're falling down is so often about delays in accessing those healthcare professionals, whether that's measured in months because people are waiting lists, or whether it's measured in hours because they're stuck in A&E or some kind of outpatient because they just can't get what they need when they need it. We've got fantastic progress on the waiting list support service, and I think that's another great innovation that we achieved in the most incredible circumstances and really shines out as something we've done so well in the last 12 months or so. Around A&E though, I think we are still struggling, and we've talked in this forum and others about changes to try to recognise that people are waiting on them, that A&E waiting is a design for. And that nutrition, hydration, warmth, and actually some basic observations are not identical in the way that we expect them to be. Could you just give us an update on where we're at with trying to progress with basics around looking after people who are waiting on them?
Yeah, absolutely. So I think there's two things. One is the actual what we're doing at the front door and the flow and how we're moving people through, because I think there's, and the other is the environment within which people are having to. So if I start with the second first, in terms of the environment, as you will be aware, we did set up a group to look at this, to try and make sure that we could actually make some basic changes that would make a big difference to individuals in those areas. We then have been very fortunate and delighted to have received a lot of funding to support our aspirations around that, and it has, on one hand, it's really, really positive. On the other, it delayed some of the orders that we put in because we weren't quite sure what we were going to actually be able to purchase through that funding. Nevertheless, I have had absolute categorical assurance this morning that the orders have been placed for the seating. I will hold my judgment on whether it's the most appropriate seating, but there's a fine balance to be had around. We actually don't want to make the waiting area the place you wait the longest. We actually need to sort out the flow through our system so that our medical assessment units, our surgical assessment units are working effectively, so you spend the least amount of time in the A&E department in the waiting area. Nevertheless, the vending machines, there are ongoing discussions now with the vending companies to our humans, workforce as well, to make sure that we've got appropriate vending facilities for hot and cold beverages. And I've had a conversation this morning to look at whether, to look a bit of detail, sorry, but could we have soup as well as sandwiches, for example? Not everyone can eat a sandwich. So there's ongoing conversation about that, but the discussions and contracts and the orders are in place. We've also looked at putting a second flow, a family liaison officer, into our ED areas, because the feedback from EDs where those individuals work is phenomenally positive. I was looking on Twitter just last week about the flow. We've gone into one of the departments and bought some decent talks. You know, it's those little things that make a really big difference to patients in our care. bottled water has already been provided into all of our A&E departments, and there's a close monitoring that's taking place to make sure that we don't run out. Blankets, I've personally spoken to the laundry department to make sure that blankets are actually available, and that thermal blankets are available as well. So that is something that's going on. I've also questioned footstools, because it's one thing to sit in a chair, but actually to put your feet up if you're there for a little bit longer is really, really important. We're trying to balance that off with health and safety. Sadly, we've had a couple of incidents in our emergency departments where items have been used to threaten staff, thrown at screens, etc. So we're trying to balance that off. And again, it goes back to what can we do to make sure people are spending a minimal amount of time in our ED departments. I've mentioned the sort of answer to question one, which is about we can put a sticking plaster in, which is about making the area nicer, but actually it's about moving our patients through and into the right areas. And I don't know whether Andrew, you want to say something about some of the work that we're also doing around that flow issue as well.
Yeah, Andrew, so certainly we're looking at, as Mandy says, the ultimate destination is not people starting to appropriate environment and rate. So we've made progress in Bwrdd over the last couple of weeks with establishing surgical assessment unit out of operation, if you like, since COVID and during COVID, partly due to staff who were managed to recruit for the following now, but we can look from that. They do appear to have been facing some benefits from that over the last couple of weeks, just in terms of being able to call surgical patients that otherwise were waiting in our ED and waiting through into those surgical assessment facilities and functions. Ideally, we would like to get them this work to do, but we're also having some more of that appropriate seating that I'm talking about, and being a market sector, more appropriate environment to be able to monitor patients. And we're looking at how we develop a key part of it, how we get people, how we can create additional capacity in a constrained environments and resources we've got around us, and that's what we create capacity. And whilst also working on all the other actions around, say, the emergency care, so keep around and then the backhaul and discharge. We have also, I'll mention it now to deal with COVID, and so we very close to set up an emergency department, so the site group, which has got 4 or 5 work streams, including patient experience, workforce, we're doing our escalation plans and our flow work, so that we've got a weekly meeting at the moment with our senior clinical leads for emergency care and the operational teams to really try and drive the urgent actions and improvements we want to try and put in place to mitigate the pressure we've seen, but improve where we will be, but we improve pressure as this case.
The next assessment units, will that be basically a portal cabin or something where people can be assessed rather than a constrained environment at the moment?
No, the medical assessment unit be a bay within the current critical decisions unit within the hospital. We'd like to, we've seen enough on the place, but that's so that's fine. I can do it now, but we are also having a conversation trying to work jointly with us on ambulance off-road unit outside of Bwrdd initially, which is our most challenged site in terms of off-road delays and demand. So that would be a bit bigger than a portal cabin, but it would be a facility that could house up to 6 patients, and we're just working through with us at the moment the joint staffing model that would enable that to happen. But we've got, as a unit, I'd like to think we would have that in place before Christmas ahead of January, so that and that will help some of that risk of cost because it's still having patient experience in the community who will help
Wow, that's great. Also, I've been in contact with Sean. I've been asking all the time about the environment, and I'm going to visit. So have a look at the chairs myself, etc., and sit there for a little while. Just one question I have on the report, if I may. It's on page 13 and 34. It's talking about cancer, and it says in wrong lines, for example, once a diagnosis is made, the patient is allocated to a named nurse who will guide them through the process. And this approach has been replicated when cancer patients receive support when attending the hospital for surgery. Isn't that the case that every cancer patient should have a named nurse throughout the health board?
That would be my expectation, and I do need to go back to confirm that that is actually happening.
Okay.
We don't have many complaints about poor communication within cancer services, which is why I think that it is in place. So I just need to go back and double check, and I will make sure we'll take the actions if I make this without an notice.
Any other questions on the patient experience report? Roger?
Chair, thank you. Just on a side note, that if you're looking at this for the first time, I mean, just back to the board, it is sobering and say some of the issues that are related to what perhaps industry, but we can't feel just with this unacceptable. But I'm just looking at the patient experience, but also the communication. And I think having looked at it for a long time, and perhaps I think your presence in this was very good, but also I think the Facebook, the Twitter, I think from looking from outside, and I think the communication in general has improved quite a bit, and I think it is important, and it works, in more than one way. I know we're looking at more at patients' experience, from a hospital point of view, but then that message is also people can perhaps go to a place like this and perhaps put their concerns across there. Not everybody, as you say, is that confident with perhaps digital and like the computers as such. So I think it is I think it has improved very much, and I think having presence on the ground does make a big difference. So just comment.
Yeah, it's good to have fresh eyes on the board as well from the outside, from the community. So thank you for that. I don't know, did you want to ask a question?
Again, it was about communication, and the other, exactly as said, and I can see that. It actually gave us the opportunity to reach a new audience, especially younger people and community partners. But it's really about communication, making our ED departments about the patient experience and how people are waiting without communication to them. I am aware of members of our communities that are sitting there potentially 4, 5, 6 hours, and people do not come and indicate how long we might have to wait. So it's a plea really on behalf of the communities that we serve, is to really think about how we have that two-way conversation with our patients that are working and what other options there are for them. And also in regards to triage, whether or not we still are operating the triage system, we do have patients working in ED that may be deteriorating and we may not be completely sighted on their condition. So whether or not this is part of the ongoing move into looking at our ED department going forward, I think we do need to be cognizant of some of those issues that patients are presented to some IMs in particular. And it might be touch points as well as certain times or certain days of the week. But I think we do need to really take note of where our patients are telling us.
Absolutely. So you'll recall that we did have feedback when face machines were beginning to be introduced sort of in the moment. And of course we had to strip them all out because of COVID and some restrictions. So they're going back in. We've got I'll fully ticketate the strips of communication that haven't been operating as effectively as they can. So currently, for example, in the Bush waiting room, there's a piece of work going on to look at how we make sure we utilise what we've currently got. And part of the bid that was included within the bid, I was really clear about this, was about electronic communication boards in our waiting rooms, so that not only could we explain the amount of time that people
more needing to be waiting, but actually deliver some really key public health messages and also some signposting to some alternative support as well. So I know that Hugh's team is working with and has got a seat around the table for a working group on the improvements to reading to actually make that happen. And also the flow boards that we've been asking for were part of that as well. So again, that's part of a major project that Anthony Tracy and the team are actually engaged in taking forward as well. I think you're right about the touch point. We can and should be doing more, recognising particularly that sadly when areas are becoming extremely busy, staff have been pulled in to actually deliver hands-on care, which is why I think the move to having enhanced family liaison officer presence in EDs can only help us with that communication response.
Thank you. Thanks everybody, and huge thanks to the patient experience team and to the arts and help. They've just done an amazing job. And I know Joe had particular experience of the work that they did with our Ukrainian refugees in Kangrama, really therapeutic.
Absolutely, leadership especially the children.
So thanks everybody, and everyone happy to receive the report. And I'm going on a 10-minute break now before we do the actual review. So we'll be back here at 11:38. I'm a lawyer.
welcome back everybody. We're going to go straight to item 3.8, which is the annual presentation of the nurse staffing levels for Wales. And I would like to welcome Louise Ellis, who's Senior Nurse Manager, and she's going to, I think she's going to give us a presentation via Zoom. So a warm welcome, Louise, and over to you.
Hi all. Thank you for, can you all hear me?
Perfectly, thank you.
Okay, lovely. Thank you all for inviting me along to your meeting today. I've been asked to come along to discuss the nursing assistant practitioner role, the Band 4 role, particularly in the acute stroke unit in Prince Philip. I'm just going to share my screen. I'm conscious I only have 5 minutes with you all, so it will be a snapshot of the role. And I will just share my screen. Can you all see that?
Yes, thank you.
Lovely. Okay. So why was this role required and what were the considerations around implementing the role? Like most areas within the NHS, Ward 9 was no exception. It was finding it challenging to fill the registered nurse vacancies. We considered the stroke standards. We had to ensure that we had the correct nurse staffing levels for the acute stroke unit. It was becoming more and more challenging to fill the 5th registered nurse deficit to ensure that there were 2 registered nurses within the acute stroke unit. We were finding the need to backfill that 5th registered nurse with an experienced healthcare, such as our Band 3 rehabilitation assistant. This was occurring more and more frequently, and it made this area safe but not appropriate. However, the experienced healthcare support workers had vast knowledge of stroke and specialist care that the stroke patients required. The issue around the registered staffing deficit became a discussion within our stroke meetings, and it was apparent from those discussions that the other sites were having the same experiences as we were in Prince Philip. In line with the Nurse Staffing Act 2016, we were unable to meet the registered nurse template. Discussions were held around what would the nurse staffing levels be appropriately met with, would they be appropriately met with a nursing assistant practitioner and a Band 4 role. We were also trying to think of more diverse ways we could fill the outstanding registered nurse vacancies, while also gaining experience and developing our experienced stroke workforce. Agency nurses were a registered nurse, but their speciality we were finding are not with stroke, and they didn't have the knowledge of the stroke care and the targets or standards that we were requiring for our unit. A further driving factor was to create further development opportunities for experienced healthcare support workers within the ward area. We had a healthcare support worker on your Grow Your Own programme, one of which has is due to qualify this year. We have had 3 Band 3 rehabilitation assistants, which often put that healthcare down the path of a physiotherapist or an occupational therapist role rather than nursing. So how did we achieve it? We were aware that the nursing Band 4 assistant practitioner role had been agreed by the Health Board and had passed by the internal scrutiny and approval group. We looked at the job description, which had been developed by this group, the induction, the development pathway, the scope of practice document, and the core competencies. We discussed the consideration with these alongside the stroke standards that we had to maintain. We made additions to the core competencies by adding stroke-specific competencies, such as understanding and having the ability to implement the stroke pathway, to understand, perform swallow assessments on stroke-specific patients, to understand and input the SNAP data for the stroke patients. All the competencies are mapped against the Level 4 Certificate Higher Education and the NMC Nurse Associate Proficiencies, and have had a practice assessor and supervisor to assess these skills. So as a result, we achieved progression and development within the unit, job satisfaction and support of many levels within the unit for the Band 4s. These posts are also a very exciting opportunity, which when available, they spark much interest and excitement on the whole site. We have maintained the stroke standards and stroke care within the acute stroke unit, and we provided evidence-based, patient-centred care. So this I'd like to share as a quote from one of our Band 4s who are currently in post. My Band 4 role as a nursing assistant practitioner has given me the opportunity to expand my knowledge and skill set, enabling me to further support and alleviate some pressures experienced by the recruitment of registered nurses. This role not only benefits the workforce, but it promotes the patient experience, patient safety, and best patient outcomes. And Zara happened to be one of our Band 4 rehabilitation assistants before she had this post. So the progression had been in a Band 2 before that. So the way forward. The success of this role in the acute stroke unit has encouraged us to develop further Band 4 roles. We have currently one on endocrine and gastro on Ward 5 and one just started on the orthopaedic ward within Prince Philip. We also were thinking of other diverse ways of helping the recruitment. So we have employed a pharmacy technician within Ward 9 as well, who again, like the nursing assistant practitioner role, has helped the workforce greatly. We've ensured that we are constantly maintaining the stroke standards, while also maintaining high standards of evidence-based care we deliver for all our patients. This new diverse way of thinking about different roles within the health board supports the team around the patient model, and that is always something that us nurses are striving to achieve. That's the end, so I'm happy to answer any questions you may have.
Thank you, Louise, that was excellent, and I've had the pleasure of meeting your practitioner with Mandy on a patient safety basis and the whole team, so, and you can see the difference in reality, both to the patients and to the morale and the team that's made. So I'm going to open it to questions. Judith.
Yeah, thanks for that. Do you see this expanding to other areas? And I'm probably going to commit sacrilege by saying this, but having been around the NHS for 40 years, I'm afraid feels like the enrolled nurses, which we threw away all the time. But I'm sure if the former chief nursing officer was listening to me, she would be very happy. But that aside, do you see it expanding into other areas?
Shall I answer that, Louise?
Yeah, if you want to, Mandy, yeah, that's fine.
Yeah, so yes, the answer is yes. And actually, we've been working hard on a number of different areas where this isn't about replacing registered nurses. This is about looking at what the patient needs. And in all of the areas that we're working on this, we've taken a very pragmatic approach. We've identified the skills that are needed to meet the care needs of patients, and we've put in different roles. So the assistant practitioner role is something that we are driving forward, and there are national competencies that have been developed, and we then, as you've heard Louise say, have added to those specific to the area. So, for example, the surgical units, the surgical assessment units are somewhere where the assistant practitioner role is key for us, and making sure then that they've got the surgical specific competencies to support them to deliver the outcomes that are required. Up in Ward Glass, we've also got a technician role that previously was undertaken by a registered nurse, but actually in our cardiac unit is having phenomenal success and again impact on the way that patient care can actually be managed in a very different way, but with improved outcomes and timeliness of response. So I think watch this space as part of, as Louise has said, the team around the patient model. It's not something I can create very, very rapidly, but it's something about bringing teams on board, team at a time, service at a time, so that we can actually create the right workforce meeting with our individual patients. And I wouldn't look to frown too much, Judith, in terms of the old enrolled nurse. There are differences, but The other thing just to add is that the new Chief Nursing Officer, not quite so new now, soon, is also looking at the impact of the nursing associate role that, as some of us will know, has been in England now for 5 years, to see whether that is something, again, that we will want to introduce here in Wales. If that does progress, then we will also then have to take stock of, so what does that mean for our assistant practitioner band 4, because the nursing associate role is also a band 4. The difference being they are on the register, our assistant practitioners aren't, which is why the competency assessment and sign off is absolutely critical. So that, as Louise has said, evidence-based practice and patient outcomes remain central to what we're doing in the role that we're introducing. So it's a bit of a long answer, but hopefully give you a flavour of how we're taking it forward across the organisation.
Thanks, Nancy. Chantal?
Yes, thank you, Chair. I mean, I remember the days of the state and home nurses and how valuable they were to the workforce, and certainly when I was in myself on the we did have a high number of state and home nurses, so I welcome that development. I think for me, it's perhaps it's through ignorance, but I don't know what the training looks like and how consistent that training is going to be when you start to roll it out to other areas, and how do we ensure that they have the breadth of knowledge in order for them to be able to bring in the solutions to the problem.
Louise, I don't know whether you want to pick up and give an example of how your assistant practitioner, the education route that they've gone through to get to where they are. A practical example.
Okay, yeah, of course I can. So as I said, when you saw Zara's quote, a lot of these are experienced healthcare support workers who have been within the health board for many, many years. And we were very lucky that the two that we have worked on the stroke unit for over 10 years. So their stroke knowledge was already exceptional. They then worked alongside the experienced registered nurses, and the registered nurses then they had a particular supervisor and assessor, and they would assess their competencies, ensuring that they were competent to carry out that band 4 role. And I know that is what's happening on Ward 5 within Prince Philip as well. Again, the same competencies, but more endocrine specific.
And the other link I know Alison wants to come in is with the work that we're doing around Grow Your Own. So they're linking into the different levels of education, level 2, level 3, level 4 education. And we would hope that this would create a pathway, an additional pathway into registered nurse education as well. So it's an opportunity for people to step into a different role, work at a different level through delegation of the registrant, and actually move on into further education as well.
Yeah, it was just a while ago this has been brought to the board's attention previously that actually there's been a lot of work done around the band 4 training for therapy practitioners, and we're the first health board in Wales to actually get that up and running. There's a formal training programme now. So it may be worth, if anybody wants to have a conversation with Will, we can share that information, because it may be something, I don't know how easy it is to tap onto, but rather than leave it we.
I think Mansell also has a question from the Community Health Council. Can you try and come in, Mansell?
Yes, thank you. Thank you, Chair. Could I just ask Louis, can you hear me first of all? Because I can't hear you too well all morning. But can I just ask Louise how long this has been happening on Ward 9, please, before I make any comment?
So this was started at the beginning of the year. So we started talking about it about a year ago. Obviously the competencies had to be written up and everything had to be passed. But we employed them in April.
Yeah, okay, thanks for that. And I'm happy to share this with the board from a personal perspective. As you may well be aware, I was admitted to Ward 9 in March. And I must say that I found the communication and the care was second to none. So, and I really made some good communication and partnerships really with the healthcare assistants. So I can only thank everybody so much for that. And that's a personal opinion. I think this is a great innovation going forward. And I hope that it will be pursued right across the health board. Thank you very much.
Thanks, Mansell. Mansell, I think everyone else has been able to hear, but there will be a recording of this session on the website if you wish to re-listen and be more clear. So sorry about that. I'm going to bring in Lisa.
Thank you. Thank you for the presentation. I think it's excellent, and it's great to see that all the work we've been doing over the years to develop our best support workers and assistant practitioners is finally coming to fruition. It's just to update the boardroom that our 2019 apprentices are now starting their assistant practitioner level 4 training. So they're already on their route to their registration. So it's just to say they're at this level now.
And when they were the apprentices that came to the board just before COVID, one of the best boards we've had. Yeah, 42 young people full of energy. Yeah, that's great to hear. Thank you.
And actually, picking up on that point, I know we're actually looking to see where we can put those apprentices now as they're developing, so that they become our next cohort of assistant practitioners. So it's all joined up.
You know what strikes me in hearing this, and Louise, thank you so much. And as I said before, I've physically seen the difference. What strikes me is, as you said, Lisa, this is after many years coming to fruition with the apprentices, with the people who are healthcare support workers, etc. But we're not cited on the workforce plans in social care in our area about having associate social workers or other types of people who can do assessments, who can support people rather than the traditional way. I'm sure it exists, but can we bring that to the board seminar as well, please, so we can see, I'm sure there's some cross-learning in tab here, but I think knowing our boards and knowing other boards in Wales, we are way ahead in this field, and health education improvement Wales has said that. So if we could kind of share that with our colleagues and see how we can look at a different type of workforce to help unblock our systems and serve our citizens.
Yeah, I can pick up on that. We have done a piece of work of joining with this, and I led a piece of work on a regional basis around induction training.
Yeah.
And I think that already delivered benefits, because actually helped staff better understand social care workers roles and vice versa. And that definitely, through the skills development on both parts, made a good foundation for us to go forward. Of course, here in Ceredigion, we have got some integrated workers, which we piloted. So I think there's some really firm footings there for us to progress forward. But it would be helpful, as you said, to look at where are there further opportunities. And I know Lisa is already engaged, certainly with Pembrokeshire colleagues to take that forward.
I know in Pembrokeshire we've got the integrated health and care apprentices. Yeah. We've got 12 of them, haven't we? Yeah, but I would really welcome that, because it doesn't necessarily have to be a social worker who does assessments, as it doesn't have to be a fully qualified nurse who cares for the stroke patients. There are different ways. And
I'm just picking up on that. How, again, communication. I think communication's on my brain today. But how are we actually communicating with our young people to access careers within the health service? Because there are some of our population that may not want to go away. I know we've got our school nursing here in Aberystwyth, but they may not want to become a fully registered nurse. So how are we really showcasing the opportunities for our people that actually our people here in our region?
I'll bring in these first.
Okay, so we have individuals in our workforce development team who engage with local schools. We've reached a partnership with a number of our secondary schools, in particular now, around a joint working arrangement, so that we will be actively part of their careers events. We've just appointed a lady who will be joining our workforce development team on the 8th of December, who is a teacher by background, works in a college at the moment delivering health and social care. But because the curriculum in Wales is changing as well, and it's more vocational education, she is going to be helping us to say that we can go into schools and actually I can give a teaching plan, I can write a plan, I can give the resources, to actually be able to teach them at a time, and therefore they'll be very receptive to how we can help them deliver what the career opportunities will be. within our area. So, we have our apprenticeship programme. We've just appointed another round of individuals who will be starting in January. And that feedback session was last week. So it's very much on our radar to be getting out into schools. And of course, we're in Cambridgeshire College recently, and Amanda, our head of people development, was also talking about how to get into the health board.
We interacted, and Alina was out with building planning with a quiz with over 100 students. Steve and I were there as well, and I asked us to go back because some subjects, pupils studied certain subjects, didn't get an invite, so they're jealous. So they'll ask and we covered the whole range: estates, gardening, cooks, cleaners, IT. So that is continuing. Ali.
Yeah, it's just also to add that we've got a number of people that came to work with us from the vaccination perspective, and obviously from next year we're looking at different models, and we're actively working with them to support people who want to stay in health or to apply roles that we have as well. So we, hoping that we will keep a good number of those in those to really help it.
I know Louisa's got a meeting at 12. Thank you so much for joining us. Hope you can come in person next time, or we'll come to you connectly. John Barr, thank you. Take care.
Thanks, Louise.
Thank you. Phil?
Just around the point about schools and connection schools, we are working with Sarah Foundation about giving people who want to be potentially being a student doctor experience in the hospital as well. So, I suppose across the wide range of schools, in fact, not just our hospitals, we've got Sean James speaking to us across the system because they know what's working in primary care.
Thank you. Sorry, Chantal?
Yes, just an observation on my part, whether health education improvement girls are cited on this development, because they're increasing the numbers of commission places for nursing. But what we've experienced in terms of university, and that seems to be replicating across all of the higher education sector, is that we haven't been able to recruit to those commission members. So I just kind of wondered whether we need to be rethinking the strategy if we're creating a new pathway to qualified nurses in the future.
I'll bring these in.
They actually are cited, and they supported our very first round of apprenticeship programs. The conversation that I've been having with counterparts in Cyhoeddus is we have to do differently about commissioning. People are now choosing to take an apprenticeship route because the university is not for everybody. So therefore, we need a blended approach that meets the needs of our population. And certainly the conversations more recently is if we know that we have gaps now in commissioning, we let us take more apprentices and let us have more very own applicants because we can fill those seats with a different way.
I totally agree.
Chantal, could you connect these and share some of the detail from Swansea University's point of view to give more sort of ammunition really, or more influence in the changes? Thank you. Do you want to pick up your paper as well?
If I could, please, because I've got statutory responsibility
I know
to do that. So it's great that Louise has sort of given a flavour of some of the work that we're doing as part of the approach that we adopt around the calculations that we require to undertake on a regular basis. So this is the annual report. It is part of 25B wards. It used to be just medical and surgical, but of course now paediatrics are also included in this. And this report reflects 23 medical wards, 12 surgical wards, and 2 paediatric wards. I say that as if that's a static position. So whilst I do this twice a year, I actually feel as though I spend my life repeatedly revisiting. As the ward changes, we revisit and undertake a further calculation. So there are no changes at all for 11 of the adult medical and surgical wards and 1 of the paediatric wards. And table 1 in the paper on page 13 sets out the high level changes, which indicate both financial impact and the workforce impact. We'll note that actually by introducing some of the changes we have, one example being that which Louise has provided, we've actually reduced some expenditure on some of our wards and also the whole time equivalent differences between RNs and what we're classing as support workers. What isn't included in the overall costs attributed to those wards is the
what's set out on pages 13 and 14 of the report, and that is about the service change. So with COVID in particular, and as we've gone on to develop and move closer towards some of our strategic changes, we've actually we've built upon some things that were happening before. So, for example, the enhanced care facilities, where we've got patients that would previously have been kept in our ITUs and now being moved out into an enhanced care area and receiving a higher level of care than they would have in a routine medical or surgical ward. That has an impact. Some of our pathway changes are beginning to have an impact in terms of the way we utilise our beds, our departments, etc. The financial impact of some of those changes equates to about £1.5 million. That is not part of the nurse staffing calculation. So every time we have a surge bed or beds open, we have to deploy additional workforce. So the calculations reflect what is a more static position. However, what I must reinforce is that whilst we undertake these calculations, and as I've indicated, there are 11 wards that there are no changes, other areas do change, and there is a degree of flex. So what the cost of delivering services today may change in the next 6 months review because of some aspect. As you see, it's gone down slightly in some of our areas, and that is linked into the acuity, the dependency of our patients. And you'll see in the report the level of detail that we go into. We've got every single area that's included in this report, from incidents to complaints to staff sickness to PADRs to anything that is relevant to the safe care and delivery for patients in those clinical areas. The one thing I would say, it links into the nursing stabilisation work that I'm supporting with Lisa around the international nurses, and just to say that we've got 49 currently that have passed the ROSCEs, 33 with their pins, so they can actually work as registrants. That's as we sit here today, and we've got another 5 that have passed as well, so they'll be coming on board hopefully within the next 2 weeks. Those help us fill some of the gaps that we've got, but we've already calculated those into our calculations. So it's just to bring that to the attention of the board.
Thank you, Andy. Thank you for this. An incredibly complex, intense, and ongoing piece of work as you've described. Are there any questions at all? You.
That's Chair, just to add to what Mandy just said, so the one where it makes clear the overall financial breakdown, but the registered nurse reduction that we're seeing is on a budgeted basis and not on what we're currently experiencing in terms of a run rate where we are heavily staffing with agency nurses. So that the run rate benefit in our spend will be that much greater, about double what we're seeing there in the budget spend. So it's a good result, but we need to work through how that then embeds itself in future budgets.
Yeah, this is what we did highlight this to be highlighted.
We're both happy to accept and thanks for all the work. If we can now look back on what makes CDP's electric review. It's 3.6 and over to Phil.
Thank you, Chair. So this is a large piece of work, and I think we should recognise the importance of it in stage work, and also the public interest that there will be in this report. I wanted to start off by saying a thank you to the public who engaged in this process so far. Also to our staff and the CHC for being our critical friend through this, and also to Lee's team, Yvette and Alex and others who put this work together. It's been a big task, but there's still plenty to do. And also to Lee's leadership in it. We brought the issues paper to board on the 29th of September, and the action was to bring the options appraisal and the engagement review to this board today, and that is what we have in front of you. You'll see that this includes the options scored against the criteria, and you'll see that the options, each of them, have strengths and weaknesses, all three options. And there's also a series of detailed attachments that address the various issues within the paper. Just to confirm, my personal involvement in the process, in the detail of the process, has been quite limited. I've attended some meetings, I've opened some meetings, but I haven't been involved in the detail of the discussion to keep myself separate so I can correct my medical director role at boards. The recommendations you'll see are that we go out to consultation on the options, and also you'll see that there is a cost implication to that which we need to consider. The CHC will also have an important view which I'm sure they'll want to contribute to the discussion.
Going to open it for questions or comments.
Yeah, thank you, Phil. And echo what you've said about the very detailed piece of work. I wanted to ask about service user representation. Because when I was going through the report, whilst there's certainly sort of large numbers quoted who submitted the questionnaires that they wanted to get involved, I might be mistaken, but when I was looking at the events, it looked as though we had one person there, or two, or five, and that sort of bothered me as to whether the way in which that's been done has enabled people to engage. Because if it is attending a whole day, if you are trying to get at people who've either currently got young children or maybe in the age group who may have children in the next number of years, it's not a great way of doing it because they're either at school or college, they have young children, they're working. So I was just a little bit concerned about engagement, so I'd be interested in that. And then I guess I should say we're concerned about the cost to our ability to commit to that level of cost, but that's the conversation, but certainly about the engagement.
So is it okay if I start and I'm bringing Lee? I mean, there is a real tension about the amount of detail that we have to go through to get to the stage in both in the options development and the criteria setting and the options development. And the tension was that we wanted to be sure that we were following the process correctly. With the support of the Conservation Institute, and therefore the commitment that was required was quite significant for both staff and public. You're right that it did make it quite challenging for people to commit to all that time. You'll see in the attachments there's quite a lot of detail about the efforts that were made to try to engage with the public. But you know, that was a challenge. There's no doubt. In terms of, and we, I'm sure we'll come and do a bit more on that. But in terms of the cost, that is something we need to consider. However, this issue has been a significant concern for many years. We've had temporary service changes for many years. It's of high public interest, and we really do need to make sure we do this properly. And there's a real risk that if we don't, that there will be something in the process. Or another option might be that we try to, I suppose, build an internal team that might be able to do this work. But the problem with that really is that a lot of the cost in this is engaging with people who are independent from us and are therefore able to give an independent view. So we do need to minimise the cost as much as possible, be proportionate. But it's really important, given it's such a critical issue, that we get this right.
Just come back on the engagement bit, because is there a risk that the constitution impacts to constitutes process and not flexible enough to be able to engage with the people who are going to be using this service. And, I mean, well, I am a parent, but I'm not going to be using this service as a parent. So I don't know, it sounds as though they have a way of doing this and you have to fit into that. And if, as a member of the public, you can't,
Yeah.
well, you just don't.
Because it's not just a process, it's our obligations with our statutory duties.
Yes,
So it's their interpretation of that. Maybe.
Yeah, that's a very important point. So I think very important question. So as you rightly say, in terms of the engagement process before we go into the option, there's extensive work done to try and engage with our public on this. So as you mentioned, we appreciate government surveys and citizens responses with very good response, such as obviously TSG surveys. We're also engaging on war, for example, you mentioned with services like the time they were in, before document events, we visited to schools and help with discussion. So there was as much as we could possibly do, I suppose, to try to reach out and engage with communities and serve users in general. We've then, from that, we had 150 people who expressed interest in being involved or being informed of institutional developments. So they were all contacted before we got into the process to give them the opportunity to participate in that. We then, when we look at the individual sessions, we invited 14 to the session day, on which 2 attended, as I would say. One of the learnings from that was timings of the start and end, as you suggest. It wasn't conducive to parents to school runs and so on, so we adjusted then future meetings to reflect that, so people more opportunity. And then we had 22 like resolutions praised, of which 5 present. Although that was a small number, they were very much involved in the discussion and actually they did influence the thinking on the day, which is positive. And then when we got down to the public, the appraisal workshop, there were 30 invited, unfortunately one attended, as you suggest. That one individual was actually part of the working group to develop the option in quite a lot of detail. So that was helpful in shaping that small group's thinking of that. But as Phil suggests, it's not so much what the Constitution requires, it's more, I guess, the nature of the task. There's quite a lot of work to be done to work with potential options and assess them properly. So it's a learning process for us all. I think we'll think about this as we go forward. But we did as much as we possibly could, I think, and then it's also a mention that surveys themselves put a lot of effort into this above and beyond their day jobs, if you like. So and make the service manager that instrumental in working with that. So it's not ideal, and I think that probably factors into our thinking on presentation. But I guess we're trying to reach out to people as much as we possibly can, and at very least the surveys and the public responses have influenced thinking about our model.
That's really helpful to know about detail.
Things covering costs as well. So again, a point. So what we've done is we've tried to expedite the process here as much as possible, and recognising that this is a significant public interest and we want to get to resolution as possible. So what we did with the land, for example, is get to this point, recommend consultation, and then bring back forward the next meeting in costs. We try to shortcut that, if you like, by giving you a friend information of what those costs could look like, and essentially what we've done is just use the land consultation as the basis for that. So I don't expect them to be, these are the worst case scenarios, like, I don't expect them to be settled. And the second thing in relation to that is, because we've got a land consultation process progressing well, we're looking for opportunities to get best value through our engagements with SDL companies in order to reduce some of those values. So the single biggest figure you can see there, for example, is joint consultation analysis. we've built the opportunity to reduce that by taking two together. And similarly, if we can align events so they potentially even go flying down the electrics, then we might be able to do some option benefits to the impact. So we'll have to reduce that.
I'm going to bring in Mansell.
Yeah, thank you, Chair. I'm sorry, I'm struggling to pick up some of this discussion, but there's a couple of things I wanted to come in on this. One is that the CHC believes that the process that the Health Board have undertaken to reach this stage has been excellent, and we don't say that lightly, as you know. Service users, children, and the clinical staff involved in paediatrics have all been involved in this. And I think this, or we think this has been proved extremely beneficial as you move forward. And if I don't want to jump in the gun, but just to say that I think it's very important now that the residents of Hywel Dda, and in particular those in Pembrokeshire, have very much involved in this consultation, and that we believe for our executive team that these three options should go out to consultation. So I'm sorry if I've jumped the gun a little, but those are the two areas that I particularly wanted to bring up. Thank you.
Thanks, Mal. So that's really assuring because you sat there as independent and scrutinised the process to hear your view. I've got a couple of questions, if I may, on things. Do you want to come in first?
Thanks, Chair. So we were recalling earlier on our 2018 board meeting where we agreed out our strategy in the antigens Southwest. And so you might have recently asked a question then about how we balance the commitments we want to make around care that is safe, sustainable, accessible, and kind. And I guess we should say that kind is a given, although not entirely related to the rest of things. But if we took care that is both safe and sustainable and accessible, what's implied in that is a population of critical mass. And when that population of critical mass is extremely difficult, it must be possible to achieve in rural communities without joining forces with neighbouring communities for whom the geographical distance between them may be quite significant and certainly feels significant to residents that are covered within that geography. If we agree with that basis of premises that I've just described there, how can we include that kind of conversation in a consultation process with our public? Bearing in mind, it seems to me that it is inescapable that in order to do all of those things, we have to face the realities in our communities that simply don't provide the critical mass that we would have if we were in a metropolitan area, for example. And equally, how do we mitigate or talk to the public about how we mitigate their very reasonable concerns about those geographical access issues through this process of July?
I'll try and start. Thanks, Anna. I suppose those sort of relative trade-offs that you're describing there are come to life in the table that's on page 3, in the way that the public has scored and the staff have scored the clinical viability and the accessibility and others as well. So, and you can see that some options score higher on access and some score higher on clinical viability. And I think it'll be important that through the consultation we agree to that today, and we agree to go on with the 3 options, that we find a way of having those conversations with the public. And it may be that we need to give some thought to how we make sure that those conversations do happen rather than perhaps having a too superficial level. So it may be in some of the ways we either pose questions or when we set up how we interact with the public, that we encourage that dialogue to happen. So we understand both the public's views on the relativity of the area's safe, sustainable, accessible becomes, but also ideas around mitigation and thoughts around mitigation. And so I think we need to take that thinking into our planning for the consultation.
Yeah, I still remember that motion. I still reflect on it, because it was a bit of a moment, and an important moment was about sort of trade-offs in having our system, which was part of the question. I think the consultation going forward on this, and I think it is the volume of work done here does slightly speak to this, that we need to be very transparent with the public about the fact that actually what they're three separate roles leave behind the side of it, which you say is sort of given that we should they're actually all interrelated. So thinking about accessibility, which is the key concern. If we don't have a sustainable service and have closures at times, that really impacts on the accessibility. If we have the wrong sort of service, then the ability to create a safe service we see the right and condition at the right moment is also complex. So I think it's going to be in the art of the consultation to say actually all these things interact, and one of them is not really putting in the other. What we're trying to get in the public is, have we got our assessment of the trade-off for like an individual assessment? That's quite a difficult thing to get over. I think that's going to be the challenge of this consultation. Goes back to the cumulative.
I have to add as well. Within the reports, I'm well done to the team, and our CHC did excellent piece of work. There's some real gems in there about mitigation now. Whilst this model is in operation, this temporary model, so some of the things are in there so simple, like better signposting in Bwrdd, so that people are not used to that hospital, who are travelling from Pembrokeshire and find the way with their children as quickly as possible. The overnight accommodation, maybe it's time to revisit that based on the demand that we've had since the temporary change. The communication, and I have raised it internally that I've had 3 separate. I live in Pembrokeshire. I also know a lot of young mums, and my own children obviously went to Bush when they were ill, and I had my baby there a long time ago. But I've had 3 young mums raise to me that they went to our hospital with very sick children who were then inpatients when they got to Bwrdd. So we can mitigate that now again. I know we're going to have a further comms campaign this winter, and we need to do that. Constant comms, really, because people come and go into the area, etc. And then the communication between Bush and Bwrdd A&E, when the children arrive, that they're actually seen or straight to the ward. I know that has had hiccups. I think we've seen that in our patient experience before as well. So mitigations now, with the cost of living crisis, actual travel to get to Bwrdd. So I know I'm talking about the details, but the details come in from that 6,000 people, or how was it, 6,600 people feedback of real life lived experiences within that area. If we can look at that as well as that question, and we can use those examples perhaps in the next part of the consultation, because there's always that in a rural area, that sort of not conflict, but that pushing against each other of those 3 things. And Steve and I were in a meeting yesterday with all the chief executives and chairs to talk about the wonderful model in one of our capital city. We haven't got 4 AEDs. We have a rural model here. So I would like, please, for the jewels of the information there, for the mitigations now that we can put something in place. And one I said, I don't know if this is possible, Andrew, but you're doing all this stuff for A&E Bwrdd, but a PEDS entrance, or not going into A&E at all, because that is not a good environment for children. And I'm hearing some stories, even a mum with a baby having to wait in a car. So we could look at some of that now. But can we get to the issue here? The issue here is, do we go out for consultation? Do we approve the recommendation to formally consult on the options? And I'm taking into account, it is critical, it's massive in Pembrokeshire, this issue. high public interest. We want to do it properly. We are an organisation which got 62 million deficit? Yeah, and we're in charge of intervention. Well, what do we put first? What we put first is doing the right thing, what is right for the people who we serve. So do we go ahead? I know it's indicative, and trust our teams to cut the costs and merge it together and reach as many people as possible. Michelle, do we approve the recommendations? Yeah? Okay, thank you. And we will take the hit on the money. Okay, yeah? In that way we can. I'm looking at you, it's not just you, it's not executive team here, and I don't know where, but we promised the people of Cambridgeshire this for a while, and we need to do it. And we've got to use the way it's up, like your team has done so excellently. Okay, thank you. So we're on the next item of the agenda, which is the cost of living crisis. Lisa.
Thank you. So I'll start, but we're going to go to General Party as well. So what we're trying to do in this paper is outline what we're doing to support our staff and our public in terms of the cost of living crisis. So just a couple of headlines that I wanted to give out from the staff point of view. And all of this detail is in the report, so you will see in there that we are now starting to see the impact in staff saying that the cost of living crisis is impacting them in their work. So there are some people who have approached it in exit interviews, and we do exit interviews now, but people move in department as well as leaving the organisation. So the majority of people are moving for higher pay bands and to look at the hours that they work in the cost of living crisis. We have shown in the report the increase in the take-up of the happy staff benefits app. So people are starting to see that, and we've got quite a significant number of extra people around using that. We've commented in the paper as well about the Too Good to Waste campaign that we've got running at the moment, whereby food that hasn't been sold to our dining rooms is being offered to our workforce. There has been a huge uptake in that. However, we're not sure necessarily whether we're reaching the right people, as opposed to we would purchase a meal earlier and now choose to wait to receive them. So we just need to make sure that our marketing around what we're intending for that. We've mentioned Pennies from Heaven in the paper as well, which is whereby staff can give the pennies from their monthly pay into the charity. We did say in the paper that we were launching it. However, the date of the launch for the communications coincided with last year outcome of their ballot, so we've decided to postpone that until the new year, so it just doesn't feel right at the minute to be asking staff to feel any more than the other big one for us is wage stream. So we have joined forces with an organisation called Wage Stream. We interface with ESR, our staff payroll system, and allocate our options for systems for this. Thank you. We offered this a Q&A with the team a while ago, and they offer the ability for staff to be able to access a percentage of their pay at any time of the month. So, whereas in the past, and when we talk to other organisations, they have an ability for staff to ask for pay advance, people don't have to ask. If somebody needs to access any of their money for whatever reason, they can just do that in confidence with nobody needing to know why. And I think that's the beauty of this scheme. It has soft launched this week, so we have already got people who've got access to the system just to look at it and use it. It will be launched on the 1st of December. At Trade Union Coordinates were very supportive of the proposal when we discussed it in our staff partnership forum. And there are 4 key elements to wage stream. So one is you can access a percentage of your money at any time. The second is there is also a benefits tracker on there, so people can enter information about themselves and it could tell them what benefits they may be entitled to claim and how they can go about claiming them. The third is it has financial wellbeing advice and support, so it can help people track their bills, think about money conscious actions to take. And the fourth one is it has got savings scheme attached to it. So if people wanted to put £5 or £10 a month from their wages before it hits their bank account, they can collect a savings pot to restore at any time that they choose. So to try to help encourage some small savings. Very simple process. The person has to register with the app.
You then get a series of emails that tell you your application's been processed. And your monthly pay runs on the 20th of the month, and you get your normal pay slip that gives you all of the details of what you have been paid for this month. Separate to that, you then get a separate statement through the wage stream system that tells you that piece, but also says on this date we distribute £10, on that date you distribute £10. So you can actually keep track of what we've done. So I think that's a really good initiative to support our staff at this moment. So that's what we have been doing from a staff point of view. So Jo wants to just talk about some of the things about population.
So the joint courses will be looking at what we can do around the cost of living crisis for our staff, just to make sure that we're considering communities and stuff together. We've got task and finished on the first net and on the 7th of November. Prior to that meeting, I worked at the Tachwedd Directorate and doing with our communities falls into 4 key areas. One is around what we can ask for. Can you just give us a help there? Yeah, sorry. You can tell me if I'm shouting now. The first is around what we think Welsh Government's help us with and what we can advocate for. The key to this was some feedback that we've had from our schools via our healthy schools and our preschools teams around ring-fence money that they have for different projects and different programmes that actually they're finding they're struggling to spend. And if they were able to release that money, even temporarily, while we go through this this crisis, they would be able to better support families in their schools through, especially around travel and food poverty. So that's the first thing that we asked for. We also made some asks around preschool meals and around the speeds that was rolled out at, expanding that programme, and around working with our local authorities and ourselves more closely to link food and food policy and response to that. There are then things that the health boards can do themselves, and one initial changes again based on feedback that we've had through our local school systems is that we're now providing free meals to children who would otherwise miss a free school meal and when they have appointments. Sorry, sentence here. When children are coming for appointments in any of our acute sites, if they would normally have a free school meal and family on needs, we've asked schools to identify that family and to get in touch with our catering teams. We've got a system to do that, to enable that child to have a free meal while they're with us. We're currently working with our paediatric and catering colleagues on a more robust system to allow that to happen in school holidays as well, and to be able to communicate that directly with families. And there are a couple of things to work through before we know that. We've also got, again, through our healthy schools and healthy preschools teams, several projects and programmes going on around food literacy with our schools. We're building the cost of living crisis response into all our work around inequalities. The board can be aware we've got a paper being developed at the moment around our approach to inequalities and the board's approach going forward, and that will be coming to the seminar in March. But actually there is loads that now that we're in a different space with the cost of living crisis, and there is a lot that needs to be built into that, and our approach needs to take into account the situation that we currently find ourselves in, with rising health inequalities and lots of people in our communities struggling more than they ever have before. And the final, and probably the most important aspect of what we're doing is around our collaboration with our partners. We know that there's lots of work already going on in the third sector and with our local authority partners, and here through our links with BSD partners. There are several groups well established and lots of projects that are already going on to assist people in the local area with the cost of living crisis and advice around that. Following our first task and finish group meeting on the 7th of November, we presented at the Stakeholder Reference Group, talked about the work that we were doing, but also heard then from colleagues around that table of what was going on in different areas. We'd initially gone into that meeting and suggested a mapping exercise was needed, but actually the feedback that we got was that no more mapping, let's have a workshop, let's all learn from each other. So that workshop is now going to happen on the 20th of December.
Alongside that, got a registrar of public health and teachers for students in public health Wales, and so we can live with the health board across Wales, so we can again do some cross learning, see what's going well, see what's not going well, because we just simply don't have the resource to be making the same mistakes that other people have made, and or somebody else. So if we can do that kind of cross learning and maximise the impact of anything we put in place. But we're early days with everything so far, and we're building evaluations, any kind of programs that we put in our partners. So we're just getting started on this really, and it's going to be months, possibly dare I say, years before we're out of this current difficult situation.
Thanks, Jo. Thanks, Lisa. Really proud of the work that Lisa did, and it's heartwarming. Thank you. I've got no comments and questions. Lisa, Judith.
I'm going to be honest with this because when we had the meeting to look at this, I haven't had a chance to read this paper. I read it once and I read it again and read it again and read it again. And the reason why I read it so much was it really fired me up actually. This is what the health board's about. Helping our staff and helping our communities. I thought the paper was really well written. I think the paper is timely in that. I think it caused inflation at 9.4% in June. More like 11-12%, and that increases on fuel, some food, some of the basic necessities that people in poverty actually need. My comment was about how well working with local authorities and others, and the importance of those stats, I think. I mean, the other thing I'd say is, the paper says it really, really well on page 12, it says no organisation can tackle poverty alone. And the only thing I'd encourage is, because the range of initiatives are fantastic, I've never seen anything as comprehensive and wide as this. We just need to make sure we can reduce bureaucracy so we get people to access these services as much as we can. And I was more in particular thinking about people in rural communities and the elderly as well. So those who may not have access to the apps as well, we have to try and find our ways of reaching out to them. But I really commend the team, both directors, on the way the report's written and the paper.
That's absolutely obviously sharing as well, and that's the opposite we said for our access and pay that asking somebody. In my past life, I was director of age concern here in County Durham. There's millions of pounds of unclaimed benefits people are ashamed to claim, and we've got to overcome that, particularly at the moment. I'm going to bring in Judith, and then what do you think?
Thank you. Echo everything Winston said. Also, actually, quite sad reading it that we're having to do that, but that's not any reflection on all the work that's happening. One question I had, and it's because some of you may have seen some publicity around this in the last few days, around GPs prescribing payments, actually, the fuel bill, where someone had a liability, a condition where heat was critical. I just wonder whether there's any sense of that coming into Wales. It's where I know we have prescriptions, but GPs actually prescribing that someone's heating bill was paid because they have to keep their house at a certain temperature. I just wonder whether any colleagues have heard about that in Wales. Looking at Jill's.
It's not necessarily a focus at the moment in terms of something to be agreed, just agreed in contract, as you know. But we've got an meeting next week on a face-to-face basis with our government and very much looking at some of the forward issues and current issues. So it's something that we'll raise definitely in terms of that.
I'm going to bring in Chantal first because I'm sorry
Thank you, Chair. And I want to rehearse the same comments that Winston has made. It's been very well articulated. But I did, yesterday I visited on one of the engagement visits and I heard from the lead for diabetics as to the presentation of the number of patients who are coming in very malnourished and the rise in scurvy as well. And so I think it's a really well-timed activity that we are undertaking to address those concerns. But I think that again will need more impact on frontline staff of having to deal with that. So it's just an observation.
And we did have a paper at last board on malnutrition. So thank you. Rotary.
Thank you, Chair. So basically, the principal said, working with a local authority, three local authority, what, and then kind of one local authority, clearly done what's on the website now, and I think it's important perhaps that you can have a look at it and perhaps share it, but it's like a 3-page document, kind of booklet rather energy costs, financial support, the grants for the individual, rural payments, kind of warm home discount, and it's kind of very basic, as in the information is all there, free school meals, tax-free childcare. It's 4 pages, I think, the food banks and also the useful numbers. If that could be incorporated with kind of the Carmarthenshire and Cambridgeshire numbers as well, it could all be, it's like a fact sheet, it's really what, it's 5 pages. Is there a way that you could put that up in some in hospitals and also, and I think all the information is there. I think it's co-working, I think it's kind of getting that. And also, I know from the PSPs with the warm ups, that's another essential thing. I really I think with ways to kind of to supply and kind of to get these up and running. And I think getting that information out, kind of when people just walk past, because most of the staff in our hospitals are residents of the 3 local authorities, so we look after them. So just getting a few prompt approach ways of getting that information out.
Yes, thank you. Just to reassure you that we've been in touch with colleagues in local authorities exactly on that point, in the sense of not wishing to confuse people around what support is available where, but actually amplify the messages of local authorities. So we're absolutely aware of the various web resources that are available and the leaflets that have gone to, or particularly that they've gone through to school children as well. So looking to build on that.
So we're signposting our stuff to those resources.
Staff and public.
That's really sweet. That's very good. Thank you. Hugh.
Chuck, an inspiring conversation with you about the work that you've done, and there's something about a work program born out of crisis that I think fits into what all the strategic overlays we could face on in terms of social rights work and Wellbeing Future Generations Act, Operational Health System, clearly lends itself to that. But I think there's something about how we embed this thinking in the longer term. How do you think about the outcomes that generate from each of these initiatives? Where do we then want to put our relative effort? And how do we overlay things like foundation economy work, social value into this? Because it's all very much aligned. We just need to perhaps, from this immediate response, think about that longer term framing. Much as I'd like to say that declaration of poverty is going to go away, I don't think it's going to happen anytime soon. So we need to think about that longer term approach.
Thanks everybody. Thanks for leading this work. Yeah, better to say you forever grants. Thank you. Okay, we're going to go on. I'm going to chivvy everybody up now because we have spent time on things that are really important. But if that would be great. Financial report, Hugh.
Yes, I'll endeavour to keep this brief, recognising the challenges that we clearly do have. And I'm pleased to be able to, I guess, correct the record you made earlier about 62 million. We have been able to bring that down this month now to a forecast of 59 million. That's trailing there, Jim.
I like the news.
It's still a very challenging outlook and does pose a number of challenges. And while the position has been brought down, I just want to emphasise that from 62 million, there has been an upward pressure, which is a recurrent upward pressure of about 5 million to 67 million, and that's mainly related to medicines management, medicines and secondary care medicines. Now, that's outlined in pages 11 and 12, I think, of the report. So you can see that quite clearly in the charts, the graphs. And that's two things driving that. One, increased activity that we're seeing, and there's a peer that we're an outlier when I compare ourselves against other health boards in that space. The second is the cost per item is increasing, and that's a consistent issue that we're seeing across Wales. So, and we've also had some pressures in continued standard increases within Glanbwyll, that's part of what's driven that. So that's been the upward pressure to take us to 67, and then bringing that down is a non-recurrent one-off in-year benefit arising from annual leave accrual that we brought forward from last year. It's difficult to track when people take their annual leave, but in changing our policy back to 1 week, carry forward 5 days, we modelled the impact of that at the end of the year and be able to bring in that one-off benefit into the position this year. We're managing that risk now in order to give us some assurance of the delivery of 9 million through control tools that will be implemented across the organisation that gives us that assurance there. There are clearly risks going into winter. I don't want to underestimate those risks. We have to talk about the care home sector and the challenges there earlier, and clearly that is an ongoing risk and an ongoing inflation pressure as well are a challenge for us, especially as I say in nursing management. I do want to just raise that at the last board meeting we talked about the drivers and the challenges to our deficit, and I've included those in Appendix 1. That's kind of a rationalisation of our position. It's not something that necessarily reconciled, but it's a modelling assessment that we put together of the real drivers to our challenge, and happy to take questions on that and go through it in detail now. There are a couple of other things I wanted to highlight. Our cash challenge is something that we are keeping under regular and constant monitoring. It's being monitored by the executive team on a weekly basis. And we discussed the principles of prioritisation of payments when it comes to the end of the year when that pressure really hits us through the Sustainable Resources Committee at our last meeting. We're in ongoing dialogue now with Welsh Government to see how much of the funding gap, the cash funding gap, they may be in a position to fund. And as part of our process to get to certainty in that quantum, there will be an accountable officer letter that we need to send to Welsh Government in December. We need to make sure we've got appropriate governance around that, so this is not being forward between now and then. So we'll pick that up in due course. Planning we discussed briefly earlier, but clearly our underlying deficit, as I alluded to, has deteriorated. So we will reflect that over December and bring that back as part of that planning discussion. And some of that is in our ability to deliver the current savings, which was referenced in 6J, I think, on the board assurance framework, which we will come back to in due course. We receive our allocation on 16th of December, so we'll have some certainty then for the funding into next year. Lastly, there are a couple of administrative governance areas that require approval. One is the scheme delegation, which has been scrutinised through the audit committee, and the second one is a need for us to re-procure our ESG advisors. We need to re-procure that, and that consultancy contract has been scrutinised through the Sustainable Resources
Questions, comments?
Just a quick couple of questions to you. In terms of the annual leave and the model that you said you've done, what's the sort of degree of confidence around bringing that forward some back?
Yeah, on the basis that we have now changed our policy with the limits of carry forward being able to be taken, we've been able to model that with reasonable assurance into the position. So it's an 8 million benefit.
The second question, already mentioned the potential of industrial action in various areas across the board. What would those kind of pass? Any idea what the sort of financial implications are for the board?
No, clearly there will be a financial implication, and we've not included that in the forecast as yet. Clearly there will be some areas that will gain financially, but there will be clearly a significant cost from an operation and service delivery perspective. So we will be working through that as part of the work that Alison is sharing.
Yeah, two things I think. First of all, I would follow our board's information to the cost pressure, which we have in relation to COVID, sort of a central intelligence that we've got, and possibly we'll have discussions with the FPU about what their view is based upon what that output to them compared to what we did between quite up front at the early stages to what we thought was the cost pressure and recognizing that. And the second thing that I was like was discussion with the FPU, we've got a sort of hard full £25 million overspent position, which I think was more recognised in the KPMG report that Welsh Government Commission previously. So linking those two things together, what's the scale of the gas so far as Welsh Government part of the time of the intervention? You put those two things together, there's 42 million or thereabouts of our deficit, now 59 million. Is it to get to 42? Is it to get to the north? Is it to get to 25? What is the scale of gas?
Thank you. Just if I go back to the COVID questions, and yes, just to remind the board, we took a decision fairly early on in reviewing the costs that were previously included within COVID transition, that they were essentially now providing additional capacity or additional or service changes that would be used within our operational space. That's a different approach to how other health boards have assumed it. Some are still assuming that that is in itself a COVID legacy cost, the challenges we're seeing within unscheduled care and of itself a COVID legacy. As we get into next year, and that's given a degree of assumption variability across whether it's keeping an output. As we get into next year, I think that there's clarity, certainly the messages that I'm hearing from government and from finance review, that what we should not be assuming further COVID funding other than in some prescribed programme areas. So I think that clarity is helpful because everyone will fall into the same space going into next year. Which goes back to your then second point around expectation. Clearly, we are in deficit, and that's not something that we are empowered to approve. So the expectation would be balanced. Clearly, there's a transition process to get there. I think that's a discussion that is ongoing.
I think a really key question was, I guess, the first thing to say, just to go back and you said, probably start with looking at next year. There are some new volume signs there next year that the financial sector helpful, it's not just the whole lot, and the challenges that we face. The fact that we did take a decision around categorising some of the exceptional costs differently and trying to take as much into core as we thought was appropriate to do so. I think has allowed us then look at the opportunities for us to start monitoring on those things that are going to start to shift that forward in underlying terms. But this is, we will start with a very significant challenge to address. I think it underlines in my personal view, the rightness of the decision we made, because it's enabled us now to focus on those things. I don't know if there's perhaps then so given the work that had to be on the issue around a specific number, I think if you'd like to go in discussion, I think it's probably for me, for the board, to have confidence in whatever the numbers that we come up with, which has to be based on the reality of what we can deliver around some ambition. That will ensure that we've got real oversight and delivery. I think there's two things in the government's mind. One is get to zero, which absolutely we need to do. But the second is do what we say we can do. And we've got to variabilise the power to have that next year. I think next year will be a really important year for us. This one wasn't around proving that we do financial and private terms and the performance terms.
With I know this report has had detailed scrutiny of the sustainable resources. I don't say anything more asked for that.
Well, I was going to take some details.
Yes, I just wanted to ask some questions around the cost of rise in the living costs and how we're factoring that in terms of the our ability to deliver and how are we mitigating against those kind of challenges.
Chair, and thank you. Yes, the cost of utilities has increased significantly, projected to to continue. There has been this year exceptional cost funding provided by government to recognise that. But the work that's going on in terms of decarbonisation is clearly part of a response to mitigate that impact in the long term. And in many ways, the cases for decarbonisation funding that were put through much earlier on in the process, the payback for those has been much sooner than anticipated. So the solar farm, for example, in Avondale, I think it's about to go live, but that will clearly pay back much quicker than when we initially drew down that funding. And there are the biggest challenge for us at the moment in the year is the cost of medicines and the inflationary aspect of that. And that's what mainly a supply chain shortage issue that we're dealing with, especially as it's not just Wales, but the UK and globally, health systems are recovering, and therefore the demand for medicines has increased quite significantly, leading to a real constraint in provision.
Yeah, so as you know, what's good to us, the financial position forecast extending resources. But I think what we've also done is those comments are changing, right? And what that's actually land this year and also next year. I think one of the recurring challenges that we have now for is how we let our savings recover. And I think I've been reflecting a bit on that. So what are the factors that stand in our way around making our savings programs recover? And so I've been trying just to understand what those might be. I think it's to do with some of the factors that are in your paper in terms of the cause and effects of the financial position itself, demand related, some of it's structural, some of it's just simply because we're just living stand still. And I'd be interested just to get the observations of that view and other narratives on that. And more importantly, how can we change that going forward? Because I think that's what we'll be looking for us to do.
Make sure there is an expectation from government that our savings are able to deliver the savings increases quite naturally. And where we are now, so on Appendix 1, I wanted to bring that to show the level of costs that we're carrying in the system that is driving that financial deficit, and in those rest the opportunities to recover that financial deficit. But in this as well is the alignment between what is a challenge from a quality and safety perspective, a challenge from an operational perspective, a challenge from a staffing perspective. So I think this does bring those strands and challenges together. So that is driving like a strategic program of change work plan. I think there is, as we go into next year, when we look at the colleagues in this, I've been reluctant to provide an artificial target out to the organisation when there are so many challenges that are being dealt with, and wanted to really get some focus around those strategic programmes. I think as we go into next year, there is a programme of work for us to look at. I don't necessarily call it savings, but it's about addressing the drivers of waste and harm and variation that we've got across the organisation, be a little bit more prescriptive to support managers and commissions with identifying what could be done locally to contribute to that bigger opportunity. So I think there's kind of two approaches that we need to develop there. Of course, and I recognise my conflict of interest, I would say that digital has a part to play in delivering improvements. So one example would be just about to go to market in a hybrid print and post answer, which reduces our postage charges by about 400,000 or 500,000. So there are some opportunities, I think, from a productivity perspective through digital that we want to explore.
Just I think that is a key question that we could say there's a few sort of dependents on really important in that regard. And looking at it sort of from the helicopter view, probably our biggest challenge at the moment financially currently is around discharge work and the next biggest number is related to our programme business case in our current configuration. We then got staff and fragility, which is the next biggest number, and then the final one is probably a partnership with the long-term care. Actually, those are all the areas millions in order to change the current run rate of the organisation. But there are all things, as I mentioned, about the decisions we made earlier in the year that we've made, not just starting work on, but we are going to try and get some other systems going.
To thank everybody. The board happy to accept the recommendation as detailed in the report, and including to approve as the last 2 pieces. Thank you. Okay, I'm going to ask if, as we go forward, that executive members just highlight the things that need to be highlighted on the basis we've read everything. So the next item is Jill, funding nursing.
Thank you, Chair. So board members will be very familiar with the history of this, and since 2014, it falls to health boards to agree the rate across Wales for funded nursing care. And we adopted the inflationary uplift mechanism, and that was initially agreed for 5 years and then rolled forward for a further 2 years, and that came to the end in 2022. So we're asking now that this methodology is extended for a further period in the absence of any Welsh Government update on policy, which was had in place since 2004. So because it is agreed by all health boards, it still has to be agreed by every single individual health board as its statutory responsibility. So it has been considered professionally. We're making a recommendation that we do extend that, but with the caveat that we would review that position after 3 years if we're still in the absence of any policy from Welsh Government in terms of funding nursing care. So you can see that from if we agree that we extend this mechanism, the rate for the health board component of FNC will go up from circa £184 a week for an individual to £193 or thereabouts. And the full year impact of that is 264,000. 161,000 is specifically related to FNC because our funded nursing care is linked into our continuing care component. That's a further 103,000. So the total, as I say, is 264,000. It is cost pressure for it was between 2004 and 14, and that uplift used to be funded by Welsh Government, but it isn't now. So that growth element falls to us. Board members will also recall that we previously agreed the uplift on our CHC rate, so this will be further inflated as we add in the corrected FNC component. And so it's a continuing cost to the health board. It's something, as I say, that has been agreed through the court judgment, etc. So it's here for approval today, and that we recommend that the IUM is agreed for the period, and you can see the costs associated with that.
Thank you, Jill. The board's happy to approve this.
Firstly, we definitely agree. I actually think the inflation assumption is too low. I think if you do that, it's only about 5%. I know the current rate of inflation is more like 10%. So my worry is, obviously we're going to approve that, and my worry is that they're going to be able to actually have to just open it up.
Yeah, and I think I think we need to be really, really careful at the time at which the calculation is done on that annual basis. We know that we'll continue to be challenged in terms of cost of living for our care homes, and we'll look at that separately. But I think, and want to comment, that the process is carried out by all health boards with finance directors and complex care needs at an agreed point. And you're right, there will be further inflationary costs and cost of living expenses on top of that. That's included consideration.
Just to give assurance, inflation is at the moment particularly volatile, and that's a real challenge in terms of over time this will right itself. It's much like the challenge that they have nationally with writing benefits once a year when there is an out-of-pocket period, and that is an issue. Of course it is, but over time this will kind of right itself.
It's not the only cost paid in the health board that care homes get. It's specifically directed to funded nursing care component of individuals. So it's a part of a fee that's jointly paid by local authorities as well. There are other funding streams that go into our care homes as well.
If there was concern and if there was making it more fragile, we'd come back to the board.
Yeah, and so we're having those conversations on a national basis anywhere around our care home sustainability as well as that.
Cool.
Yes, just the question of the changes, I think, for the funding recommendation to the amended, given that 3 years.
and that to reflect that it is a three-year period.
And well, yes, it we reviewed at that 3-year point, and that's in the body of the paper that we said we would discuss.
So we'll incorporate that into the recommendation. Therefore, thanks, everyone happy to based on that, any changes. Thank you. Next item on the agenda is the operational updates. Andrew.
The request to be brief, Chair, so I'll try and do that so I don't very detail. That covers a lot of, covers a number of issues and is probably reflective of the overall challenge and pressure that the operational service delivery is under at the moment. I guess I want to, we've already spoken a lot around some of the system pressures that hit temporary emergency care and offered some apologies and support to the population for the challenges they're seeing in terms of access and patient experience. I guess I want to extend that to anyone currently waiting. You know, we've got challenges in terms of access across our full range of services, planned and urgent, but also want to extend my gratitude and thanks to all our staff who continue to work incredibly hard and deliver some extraordinary things in some really challenging circumstances at the current time. The sort of certain things I just wanted to pull out really, I guess, without going into too much detail is we talked earlier on around our isolation, the enhanced monitoring around a number of our performance areas. I've included the action plan we submitted on the 11th of November to Welsh Government within Appendix 1 to the report. That would actually kind of currently being reviewed by policy meetings in Welsh Government for some more detailed feedback and comments on their view as to where that takes us and whether that would be acceptable. The early feedback I've had from the policy meeting Welsh Government's leading installation process is generally quite positive as to what that says, although interestingly, particularly on some of the kind of care measures, looking to see where we go next in terms of delivery, what our next set of milestones are to go beyond the ministerial milestones for this year. So I'm expecting a meeting early December whereby we'll go through the detail of that and agree on those trajectories to the end of March. Worth noting that those trajectories and the improvement is based on the baseline position of July, so I think we've seen the trajectories that we report improvement from where we were in July already, which is hopefully encouraging. I'm sure we said before we're able to get into that process. I just wanted to confirm that in terms of the Transforming Nurse Dementia Care Programme, on the 8th of November, Jill and I interviewed the post of the Programme Director, pleased to confirm that we appointed Matthew to that post. Be aware he is the County Director from Arlington, has been instrumental in developing our response to the 6 goals programme nationally, and I know Jill and I are looking forward to working with her in terms of translating what our high-level plan at the moment is into real impact and benefit for our population. We've also tried, given where we are today, we tried to provide more local updates in terms of some issues specific to Ceredigion as a county, so there's an update there. Some update in terms of where we are with the whole strategy and some of the progress we've made on that front, but also an update in terms of the service developments around mental health and learning disability services in the county. We did, of course, 2 weeks ago extend the provision of mental health 111 request for help service to 24/7, and we welcomed, Judith welcomed, because I was late, the Deputy Minister to visit the service a couple of weeks ago, 2 weeks ago today. I think that was a very positive visit. Gives some sense of activity up until we went 24/7. We've received so 1,100 calls, 1,158, I think is that number in the last week since going 24/7. We've received 200 calls, so there's definitely an uplift in demand. And the outcomes from those calls and signposting are really positive in terms of diverting away from helping manage demand across some of our services. I think I will pause there, because I know there's a lot of report, but I don't know if there's anything to it.
Can I just say this is an excellent report? It really also meets on the bone of the performance report. And I know we discussed quite a bit of it naturally during the progress of today's meeting. But I think many teams, please. It really gives us insight the board into what's happening. Jill, did you want to say anything?
No, I mean, I think everything's set out there, but just because we discussed a little bit the last board, the update on the land practice decision work is progressing well in terms of Name and Johnston development, and we still have some challenging rotas to ensure into the longer term, but we've had interest from quite a number of different locals to work with us throughout November who are testing that. But certainly we took a good start, and that's gone very well with the health workforce team. So there haven't been any issues that have been raised by patients. Thank you.
Well done to the team and yourself. Maybe 2 questions or comments. Judith?
Yeah, because if I may, I just want to comment on the mental health content of this. I think it's really important that we get that whole range of things. And on 111, I think if you look at the table, which is on page 10, you know, the numbers there that advise to attend mainly, I know the numbers still relatively small, but 2%. Before this service, that's probably where the majority of people would have gone, or they wouldn't have gone anywhere, and then it would have escalated considerably. So I do think, you know, the team set that up. I don't want to encourage loads of visitors, but it actually is really inspiring to talk to them. And this is not just call handling, this is actual advice to people who ring or appointments. They deal with problems there and then. It's really fantastic. And the Deputy Minister very much enjoyed her visit.
Comments? I just after that, I took 3 men to save the Bush campaign to the S-Book, otherwise known as the S-Deck, in Cosby, to see how that works, because it's very difficult. We've been engaging people a lot personally, and it's difficult to visualise, but the team here were fantastic. 15 minutes waits, and I've been sincerely really some of the diversions across the board here are really commendable. The people not ending up in one with us. Any other questions on the operation report? I've got a few little things. I'll email you them, and it's just for further information. But an excellent report. Thank you. Next is the integrated performance assurance report.
David, diolch. I won't labour this report too much, but in not going into the detail, it's important that as a board we recognise that behind every metric there is a person, and I know it's a message that we've consistently been speaking about for some time. I also want to just emphasise that what we're seeing here in the summary of the report is some of the areas of investigation and some of the areas that are of concern. So in terms of the full balance of areas where there are improvements and elements as well, it's worth just looking into the linked document as well, the outcome dashboard itself. I also just want to kind of call out for the board that the language that we use, it is language that we agreed with experts and areas of best practice in this space, but it is quite blunt language to say that we failed to reach our appropriate trajectory. It is here for clarity for the board to focus on the areas of concern. It doesn't represent fully, I don't think, the hard work of our operational and clinical teams, and I do want to make sure that that message is very clearly heard by colleagues across the organisation who are working incredibly hard. And this, as we spoke about earlier, represents a big system challenge across that here. Chair, I don't propose to go into any item in detail. We've heard from Andrew and had a good discussion earlier on the challenges across the system. So happy to take any questions.
Thanks very much. And thank you for saying that about it can look really stark. Thankfully, we have the notes to show the level of improvement. So it isn't fair on staff. It's like being in school, you failed, you haven't failed. You've done a heck of a good job, we just need to keep going and do more. Any questions or comments? Okay, and that isn't because because we're really excited to board on this. Andrew, do you want to come on? Please do.
I was only going to say that I just want to say that you were talking about before, just flagging that we're making really good progress on our current care trajectories. I'm confident we will hit the pattern set out in June. There is possibilities that we could do better than that too, but I would reserve that as a big statement until we get there. It's not least because we need to be aware in terms of risk, industrial action, challenge, just to give a sense in terms of the electric world, it's 800 outpatient appointments, 50 to 100 operations a day with the effective attention. So it's just being mindful of the scale of that when that plays through. Good progress in cancer as well. Part of that recent months, and we'll continue to see improvements in that. I need to flag as well the consistency in those events and care is something we've really got to strive for, and that's part of the mass function escalation. I'm very aware that the area we're still struggling with as a service, and it's part of the conversation on tap with Welsh Government around our improvements to the developmental services, and in particular challenging developing performance improvement trajectory. It's a very similar way it's measured. It's very similar to the cancer targets. So I've asked Welsh Government if we could consider, rather than monitoring performance over this enhanced monitoring period, if we could set up a trajectory to reduce our backlog of patients waiting over the target date. Because actually, if we're reducing our backlog, our long waiters, our performance will deteriorate in the short term and the medium term. So I'm just trying to agree with them, and they seem open to that conversation. So I'm aware that's a gap and it's relevant to today's item.
In relation to our plan care and our cancer trajectories, taking into account the caveats, how are we doing compared to the rest of Wales?
In terms of
plan care and cancer,
I think we'll be in the comparative sense very favourable if we deliver. If with the information I've got, I think we'll be in a very good place relative to Wales. Is the feedback on that? Not just my assessment.
And in the meeting that we had yesterday with the Minister, she said the hair team set the targets, even though at that time we set our targets, which were a bit less, but we are hitting our targets. So we deliver on what we said so far. Yeah. Which all goes to the confidence issue as well, doesn't it? So thank you for that. Okay, thank you, Hugh. And we'll go on to the approval of the autism spectrum disorder diagnostic assessment attendant.
So a brief, I would just refer to the fact that we were aware that our capacity and is particularly challenged as part of our response to try and increase capacity within out to the markets. New for mental health too is actually more common practice in some of our other climate-based services that we can actually test the market for a provider that might be able to help provide some capacity over the course of the next year. The results of that study have come back from the paper today, and we see the board through the contract of about 4.2 million to provide 150 or 300 appointments and treatments, so 300 treatments and interventions in total, because there's more than one appointment in an intervention. But 300 interventions, 150 for children, 150 for adults, we've got really challenge waiting.
Any questions on the recommendation to approve your contract?
The questions I've got are to what extent this tender is based upon our demand or finance or market risk ability to deliver. But looking at the figures in the paper, we've got an ongoing monthly referral of something like 89. And I think that is significant for some people with that. We've got an internal capacity to deliver 40 assessments per month. We've got a tender 25 per month. So that means that the backlog is going to continue to increase beyond where it is now. And it's already something in the region of 2,500. So one way of looking at that is if we apply all of the tender exercise to clear the backlog, it would take 7 months to do it. We might get an assessment in the meantime. So what's the driver to this? Is it market ability to be able to provide the necessary assessment that we require? Is it finding finance, and where there's a gap, what are we going to be doing about filling that gap?
So yeah, the constraint is the market availability in terms of capacity, rather than allowing what we put out for. We don't have to get as much capacity as we look to close our gap. There's a piece of work being led by the delivery nationally on demand capacity and renewable environmental services. It's not just in Bwrdd, there is an issue in terms of this service as a more common problem across Wales. And interestingly, in a conversation with another health board, where we're looking for some help, they indicated that their rates were about the same as ours in terms of their longest rates at the moment. So there's a challenge there. There's a new biodiversity policy being published. I know the DU will be working through the process with health boards through November and December to work through how we respond to that. One of the challenges is there's several different types of assessment intervention approaches that you take to individuals. It becomes a very complex service to manage. I think one of the comments I've had back from March government in terms of the enhanced monitoring plan on this is they're keen to have a conversation with us with their policy needs and the delivery unit and what good really looks like in the context of the current position and challenge. So that doesn't completely answer your question in terms of what are the next set of actions. I think we've identified the capacity out there that we can get in, and we'll obviously continue to look to recruit and build our own workforce and internal response. But there's a challenge there in terms of the gap and how we deliver against the requirements of the new diversity policy in this area, versus what may be some of the common practice at the moment in terms of providing response to these referrals. I'm happy to chat outside of that.
Could we keep that in some sort of scrutiny place, such as the committee, so that we get the updates of how it is progressing based on the fact that there's a huge shortfall and the future challenge? And there's so much going on from what this says, Andrew. No other best place, Joe, that might need to think it. Probably performance. Yeah, but I could also speak all about it as well.
And then I ask a related question, so I think the question would be about capacity for assessment. But do you have a sense of what proportion of people with assessment need something follow-up? And it's perhaps treatment isn't quite the right word in this context, but some form of follow-up, and how confident can we do without simply shifting our bottleneck from the assessment phase to the follow-up phase?
And that's a really good question. It's one I've asked them. The subject of demand capacity that we're doing with the delivery development and fully understand that. To be able to provide a response to that.
Yeah, that is a big part of the scrutiny that goes to whatever we decide.
It would certainly be of interest to you.
Yeah.
I'm still not the answer to that question.
I actually went to a session at Rochester, which was to report on the review of neurodiversity. It's a very lengthy report, and it outlines very clearly what the issues are. And there's a telling phrase within there which says that the deliverers of the service couldn't agree on the most appropriate model going forward. So hence there's a series of groups being set up to work that through. And that is an outcome of what you've just referred to. The review was commissioned, the review has taken at least a year longer than was planned, so that due to COVID. But the outcome of it is not a model for delivery of neurodiversity services, because everybody's doing it slightly differently. and apparently learned to put agree which was the best way of doing it, which makes boundaries without one outcome, one is good. So it's, yeah,
I'm just taking advice from the board secretary with these, due to the impact on the individuals, it should go policy statement, but we can incorporate all those points that have been discussed. It's obviously an ongoing process, has been delayed. Thank you. On that basis, although this isn't sufficient to cover the issue, the demand at the moment, as the board's having to approve. Okay, approve the recommendation to award the contract. Thank you.
Just wanted to, I guess, socialise with the board that this is part of quite a complex piece of procurement work that is being undertaken through big colleagues in mental health. Now, in scope for, I think there are lots and lots of things. There's about £9.5 million worth of activities that we would be looking to procure through external support. That process is being supported by procurement. It's a very complex piece of work because the services themselves are complex and interdependent, and that will come back through. I have asked for people to come through Sustainable Resources Committee, just like that process, and there are certainly a number of contracts in the band that we need to come back towards in the new calendar year for award.
Thank you. Thank you. We now go on to 4.6, which is South West Wales Regional Pathology Services. Over to you, Andrew.
There's no recall that some time ago they helped me agree the regional business case for the centralisation of quality services part of the regional programme into a location in Swansea, which is subject to a business case with the bill that they particularly related to cellular pathology, water services and immunology. As part of that process, one of the issues that started to arise was how would you provide a management arrangement for the service across to health boards? And so at the beginning of this year, January, February time, I was asked to establish a task and finish group across the two health boards to work through how we would establish a joint management model between two organisations and an associated governance framework. It's fair to say that that conversation and process has been far more complex to work through than we probably anticipated at the start. I thought would be a quick 2 or 3 month piece of work. It's taken most of this calendar year to work through, and in order to get to this point, we sought legal advice through shared services to help provide analysis of the advantages of the different models available to us. When we went through what was out there that would work, there are 3 particular models that have been adopted in NHS Wales historically, and on the basis of the legal advice and options appraisal process we concluded that an operation delivery network would be the most appropriate model to recommend to establish for the governance arrangement for a joint management arrangement. That's the same model that applies to the export network, as an example. We did explore the managed clinical network option, the legal network, but the lived experience of the two, we felt that the main export network is probably better fit with the principles that I know I brought back several months ago now. So it's important to stress, I think, at this point that the taxing industry was actually set up as a low-cost governance. If we were to support this, and this paper is going through the Solvency Day board at the same time today, it supports commercial today as well. The next step would be for me to reconvene the taxing industry and review the terms of reference about how we would go about implementing any arrangement and the time frames and the process for doing that, working back from sort of some of the detailed considerations we would need to make around some of the workforce considerations, some of the financial budgeting arrangements, because we've not got into any of that detail so far. It was purely to arrive at what would be the best governance model. Just to finish challenge using art. I think it's going to be a good job of putting together a context topic into the paper that I hope is understandable and readable and takes the context issues
Andrew, when if the board approves Earthboards and it gets to the next stage, the implementation stage and all the complexities, how long do you expect that to take?
I don't have a feel at the moment of the timeline that I've put that without working through it. I know there's a desire from Swansea in particular to progress this quite quickly. And there are some services to progress this quite quickly. So we know between the two organisations we've got some critical posts that either currently vacant or will be becoming vacant. And so we wouldn't want to, what we're trying to avoid doing something in the interim unnecessarily whilst we're trying to move towards a joint model, and some of those issues around multi-service and other things that we think that we could actually help mitigate some of the challenges, service challenges by moving quicker to a joint management arrangement and sharing some of the expertise across the organisation. So we would look to do that as and when those issues arise. I think I need some time with the group just to sit down and work through the detail about some of the elements and take that you get into the nitty-gritty of understanding, even just when we talk about workforce, who's involved, when we talk about budgets, what are we contributing, what the Swansea contribute, what constitutes the budget. There are lots of considerations just to work through the details. So I don't feel in a position where it's today to give up the timelines like that.
I think just to answer that, we will of course be cognizant that there's a lot of staff involved in this, so time will take as long as they need to check the staff go through the process, which I discussed with the chief executive.
Also, one regulators are not involved in these services, and having experienced the fallout, quite rightly so, of these very sensitive services not being running where they should be, it's really important to get the delivery right. I think as a board we would support you to do it in the best way possible and resist any pressure to do it quickly, just for the sake. Any questions? No? Okay. Well, a huge thank you for the piece of work and the complexity and the partnership with Swansea. We have this support supervising improvements. Yeah, with the caveat that we support the implementation going with the, I don't know the words are, but Joe can find the one after a pace that ensures workforce and quality safety for the agents. Just wanted to ask as well, this is a regional development. We've all been down that road as well, that can be challenging, whoever the partners are. How are things going with other regional services? Because I hear that Swansea Bay doing a lot of changes as to where they place the services that our patients access. And I just wondered if we can have a quick summary of where that is.
I think there's two or three issues there that it's worth being aware of. So, firstly, we know that in December, Swansea are planning to reconfigure personal residence care service, in particular emergency safe, moving the servicing out to single sitting, centralising that and co-locating them more often. You and I met with my counterpart there earlier in the week as a touch point really, just to get a bit more understanding of what that would entail. The assurances that she gave us were around the phased approach to that change process. So to start with, it would just be 999 to December. It's not a big bang, moves in 1 week. Move the next stage would be the GP referrals in January. Alongside that, there are some, and obviously one of the things that there's a couple of things that we're concerned about in terms of that conversation. One is the potential impact on non-listed sites and any consequential impact on some of our services in terms of emergency ambulance, diverted intelligent, divert protocol that last operate. But also, we're obviously reliant on, obviously, some key aspects of our tertiary service provision of our populations of our tertiary pathways. So we should be able to register them access to hardware service, tertiary private services is something in our corporate risk register. I know there are also a couple of other issues that have been flagged in the last couple of weeks around potential impact on inpatient vascular, our tertiary vascular pathway or inpatient basis internationally, and some decisions they made locally to take a ward that was partially vascular and partially medical surgical and use it for complex orthopedic patients, which is a significant group of patients and waiting list they're trying to manage as well as their population. So there are conversations which I think this issue and we need to monitor quite closely the impact of some of those issues, and through our arch conversations on the sort of regional services discussing like orthopedics, I'm sure we'll continue to have discussions with them around what the impact of those pathways are. I don't know whether you'll make one up.
Yeah, I suppose it does raise some concerns as you described about access for our population to, or an impact on access to our population, both on specialist beds in Wilson, but also the risk of impact on unscheduled care flows into our hospitals, and that would then the impact on access for our population into our beds from an unscheduled care perspective. And we know that even big hospitals are impacted on relatively small changes in flow. And so I think we would need firm operational assurance from today about the mitigations that are in place to avoid that impact on our population.
The major one mitigation that they have taken is that they were planning to close a number of beds in single to the medical room. One of the things they've said to us this week is that some of those beds are open to help manage slowly, so that's too far.
Yeah, I think it's probably a reflection of the speed at which all the hospitals are working at the moment. Probably fair to say about the conversation we had, probably formal. You can talk today on all of the changes how they interact and their mind and so I just want to make sure that they'd be happy to, whether we might invite them to our committee, just to describe the changes they're making and provide assurance about both the ambulance changes that we may have with vascular access and with the maybe a good opportunity just to scope to with that.
Do you think it's best going to minerals committee report?
But I just thought actually what we're seeking is a short form assurance that put in place
and that's fine, and it's an open invitation to members anyway, and to execs who wish to be as active.
It sort of feels like that's where our scrutiny is being on the rights and wrongs of their departments, their departments simply about assurance.
Thank you for that. I think it's important that the board has the opportunity to be cited, and as Steve said, a lot of things are happening, but we also need to got duty as well to our schedule. So the next item of the agenda is strategic enabling group update. We have the paper.
Chair, I just want to thank members of the strategic enabling group and the agreement to pause our work to complete.
Thank you. Everyone happy with these two reports? Super. And the reports, Community Health Council. I don't know if Marcel wishes to come in.
Thank you, Chair. I think it's me rather than Mansell handling this item. I'll keep it pretty brief. We're really grateful for the inclusion of this report on the agenda today. It's likely to be our penultimate report before we're abolished and subsequently become the new citizen voice body in April next year. I won't give a detailed overview, but we'll note that 2021 to 22 was a year where we continued to develop our methods and approach, just as the public have sought to access NHS services that are under huge strain. We heard from more people than ever during this period, and we did that by extending our use of social media, dedicating more of our resource to public engagement, and we've maintained both a general national survey throughout the pandemic, as well as surveys that have been more service or topic specific. It's important to note, I think, that we've continued to hear positive stories from the public about their experiences, and they do highlight the caring approach and commitment of staff. At the same time, it probably won't be any surprise that some of the public have raised an array of concerns about accessing services, their experiences in busy settings, particularly emergency departments. People have felt isolated from their care as they wait extended periods for diagnosis and treatment. And yeah, I should say that as I sit here using relatively measured corporate language in a meeting setting like this, I do risk underplaying the impact of some of those stories, some of which have been genuinely harrowing to read. Having said that, I think board members can be assured that where issues have arisen, we have found health board managers and colleagues to be really responsive and helpful. I'll pause there. Happy to take questions, but know that probably only about 30% of what is being said is audible today, so we'll have to do my best in terms of hearing any questions as a result of that.
Thank you, Sam. We'll try and speak up. And as I said to Hansel, hopefully you can access the recording of the board online. Other people have been able to hear. I think there must be something with our connection and yourselves. Any questions on the CHC report?
Just two things, maybe not for now, because there are several issues, but at page 11 and 12 of the report, the CHC highlights things which we did, the changes which we made, which were both which were not civility, but useful as which went through the report, which category, to have our understanding of how that would. And obviously, they highlighted the concerns that they had at the time. Year opportunity services, so they might sound nice in that year is instead of being housed to what they
Sam, did you get
that? I think I've got the gist, so I'll answer. If I'm missing anything, then we can follow up. I think in terms of some of the changes that we were commenting kind of generally there on page 11 or 12, it's clear that the pandemic really forced some innovation and much better use was made of technology. And I think we reflected that some people really benefited from better virtual access to services, particularly working people who, for example, didn't need to take a whole day off work to access a virtual appointment. They didn't have to travel. But at the same time, some of those new ways of working haven't suited everyone, and that greater focus on virtual access has made some feel quite distanced from their care. Another example would be we really welcome the health board's commitment to communicating with people on waiting lists via the waiting list support service. Although I think we'd probably say that hasn't met yet the overall level of need around people being kept in touch with their care journey. So I think for us, we'll be really continuing to focus on people's experiences of those areas where there's been important innovation, which may suit some and not others. So that's quite a general answer there for Paul. In terms of maternity, we've maintained quite a close interest in maternity ever since local changes to women and children's services, alongside some of the wider headline grabbing national concerns such as the Cwm Taf review. I think from our perspective, mums and families tend to be positive about their experiences, but reflections can be mixed. We surveyed in 2021 and we used a focus group approach. Since then, we've undertaken a follow-up survey and we'll be publishing those findings in coming weeks. Overall, I think there's been a picture of improvement. We get some really positive comments around the community care aspect. Unsurprisingly, concerns around environment have reduced since the opening of the special care unit and the new maternity ward in Glangwili. And there have been specific improvements, things like management in gestational diabetes. What does still seem to be an issue is mums wanting to access breastfeeding support. And if we do hear less positive stories, they tend to be from first highlight worries around women not feeling into that. Of course, the pandemic has muddied that picture because typically COVID-related staff shortages, whether on the wards or, for example, some of the health visitor shortages out there in the community, those tend to contribute to these kind of concerns. And you know, again, visiting restrictions probably amplified those concerns. We have felt welcomed by Catherine, head of midwifery. And whilst I think there have been barriers to our members visiting clinical areas in terms of our own visiting approach and infection control approaches, it could well be that maternity are the first visits that we restart, whether that's as a CHC or in a new CVB. So hopefully that's answered those questions.
That's helpful, Sam. I'm sure the maternity and follow will be considered by our quality and safety committee. From what you're saying, you know, the fact it's improving, I think that's really important, particularly because that was mentioned in our targeted intervention. So thank you. Any other questions? No, thank you, Sam. Sorry about the sound quality. I'm sure we'll come back with more specifics in our ongoing dialogue. So, thank you.
Thank you, Chair.
Okay, we now go on to the SRC committee report. I know we discussed a lot of this today.
Yeah, I'll just keep it really quick, which are the master chronicle consideration mentioned improvement. So the first thing is how to live Wales, proposal for report committing more resources and public consultation and use of self-consultants. Committee recommends the board approve that. The amount of money concerned is currently £235,000 which is not all about it this year, but it's more of a commitment towards that. The second area, I'll take it all together. I think it's best. Second area is citation terrorism control committee. We've got the demobilisation task force group reporting, which is right on the way. Third thing is that the board of NHS primary care personal data services committee needed to recommend follow through results. And the last one, which I think he's already mentioned in his report earlier, was around the approval of the tactical
Thanks, any questions or comments? The board's happy to accept that and approve. Thank you very much. Next item on the agenda is the SDOC update report. No, sorry, yesterday, may not over to you. Yeah, that's fine. Do everybody have any questions on this? No, thanks. Next is the people report. Chantel.
Nothing to add to the report that's been presented today, but just to commend the team for the papers that have been presented to the committee. Actually, it was my first chairing of the committee, and you know, we had very healthy discussions around all of the items that were presented at I just want to
I'm really glad we created that committee and what it reviewed, rather than being hidden away. It's probably the most important part. It's not too loud, so thanks Chantel. I'll really pass that on. Rebecca, any questions?
straight out of the bottom of that issue with regard to the IT that's required for the research facility from House Office Development to be something that is thinking around the research information that we can possible capital funds, but the further do that and those will also be implications to
That's a million good for the solution.
Do that in place.
There has been some progress, but I would like to still.
Put that in the table of actions and then report back it. Committee update reports. Are there any issues or comments on those reports? I need to approve the mental health registration insurance. And it covers the CFC updates, critical and the staff partnership. What have to approve that? Thank you. And then the working partnership joint committees. Any issues on these committee reports? No, and statutory partnership update.
Just to highlight the work the PSB is doing on the assessment of local wellbeing, bearing in mind the conversations we've had today, I think that's really important. And also the fact it was National Carers Day, the West Wales Carers Annual Report went to the RPB in the last week.
I think we also need to revisit our service partnership. We have so we can do that outside of board. Thank you. And then board member webcam. Thank you. And then next meeting. So this is pre-Christmas, isn't it? We've got a seminar. Next week. Okay, we'll have a proper Christmas next week. Well, the next board meeting is the 26th of January. We're going to stop now and have some lunch, and then we'll come in committee. Well, thank you, everybody. I think the discussions have really been concentrated on what's important today. Thanks for all the hard work.
So in addition to we've got new Jones at your French, so we've got community emails in the next door, emails in the lunchtime, super team, or if you are eligible as well as COVID,